this session. We're going to start off with Dr. Ahmed Hanafi, who is a clinical psychologist at Zayed Military Hospital and the founder of Egyptian Institute Cognitive Therapies. He has a PhD and master in clinical psychology from Cairo University. He's a certified cognitive behavior therapist and schema therapy trainer for Egyptian psychologists who seek to be licensed as psychotherapists. Today, Dr. Ahmed is going to talk about efficacy and effectiveness schema therapy program for personality disorder, a case study. Please welcome Dr. Ahmed.
Dr. Ahmed Hanafi, clinical psychologist at Zayed Military Hospital, advanced schema therapist from International Society of Schema Therapy, and founder of Egyptian Institute of Cognitive Therapies. Today, we will speak about efficacy and effectiveness of a schema therapy program for personality disorder case study. Schema therapy is an integrative approach to treatment that combines the best aspects of cognitive behavioral, experiential, gestalt, object relation, and psychoanalytic service into one unified model. Schema-focused therapy has shown remarkable results in helping people to change negative patterns which they have lived with for a long time, even when other methods and efforts they have tried before have been largely unsuccessful, which makes schema therapy an evidence-based treatment for personality disorders. The present study tested the efficacy and effectiveness of a schema therapy program for patients with other specified personality disorder. This is a single case study of a married female. She is diagnosed with personality disorders, other specified with traits from borderline and narcissistic personality disorder and generalized anxiety disorder. Systematic case study which depend on pre-post test design with repeated measures, pre, post, and 3 months follow-up. For case assessment, we used 3 scales: Young Schema Questionnaire, Schema Mood Inventory, and the Social Functioning Scale. The treatment protocol consisted of 65 sessions. We started our program in February 2020 on a weekly basis for 18 months and started our follow-up sessions in June 2021, 2 sessions per month. Since August 2021, we meet once per month. The results shown demonstrated clinically significant change was examined in the all schemes, the marital problems, anxious feelings, depression symptoms, mood swings, and her social functioning. All results discussed in terms of previous studies. Now let's go to present our case study, Lamis. Lamis is a female, 35 years old, born in Egypt, lives in Cairo, Muslim Sunnah. She is married with 2 children, both girls, 12 and 6 years old, bachelor degree of pharmacy and 2 international coaching diplomas. She works as pharmacist and life coach. She comes to therapy because she has marital problems. She said, "I feel unsatisfied with our marriage. I always feel let down and angry because my husband keeps letting his family take advantage of him. He never shares with me any of his details about himself since we got married, as he doesn't trust my thinking. We are very distant. With him, I don't feel like a woman. I feel that I am ugly. I am sure he will marry another. We have no conversation, and we don't speak about our feelings. I keep comparing him to his brothers, and I see him as a weak man. I wanted to get a divorce, but at the same time, I cannot. We fight several times a week, and he always tells me I'm crazy. I feel like I'm defective and that I am a failure. I am not capable of being a good role model as a wife, mother, daughter, friend, or in my career. I cannot fit in any field because of many thoughts of unworthiness and mistrust about my efficiency. I applied to many courses, but I left them all because I'm sure I will not be using any one of them." Also, she has negative emotions. She said, "For the last 6 months, I have been feeling depressed, overwhelmed, lonely, unlovable, rejected, and I also feel irritated, anxious, and angry because of spending my money, time, health, and car on everyone in attempt of feeling accepted. Sometimes I get panic attacks about financial insecurities or when I have fights with my husband or older daughter or my parents." She has also some of negative behaviors like binge eating problems, repeating her brother's death, aggression toward her parents and daughter, beats her hand. She has a lot of difficulties in level of functioning in major life areas. If we look for occupational area, she applies to a number of courses and at the same time then drops them after a while. Wasn't committed to her job as a pharmacist and had someone cover for her. In intimate relationship, she fights a lot with her husband, asking several times for divorce. No quality time, blocked emotionally, fights with him about his family's behavior towards her, and in her mind compares him to other men. Goes weeks without sexual relationship, financial insecurities with him. About her family relationship, she doesn't spend time with them, visits them once every two weeks, doesn't speak to them on phone, fights with them a lot, and when she is fighting, she blocks them on phone, social media, and doesn't see any one of them. However, she helps her older sister in caring for her children and sends her husband to help her out with anything she needs. In social relationships, she neglects any phone call or meetings with her friends from college, social life, or sports club. She refused to participate in any activity with the mothers from her daughter's schools, and she also has two abusive friends whom she blindly obeys without any kind of assertiveness. In solidarity time, she spends time in her room, watching movie, drama series, YouTube videos, eats a lot, cries, doesn't know activity. If we're going to Lami's roots, Lamis grew up with her parents and brothers and a sister. She was the youngest. Her father was a pharmacist, spent all of the day outside between work and meeting other girls, had a lot of affairs and some gambling behavior issues, had big fears of confrontation, panics when any one of his children face a problem, and becomes very aggressive toward the child because of bringing the problem to him. Her mother was also unavailable, worked as a teacher, spent 8 hours at school, and held private lessons after to combat her financial insecurities, as she didn't trust her husband and believed he will make them lose all of their money on girls and gambling. She was overly critical and used physical punishment on anyone who makes mistakes. The big sister was responsible for Lamis in feeding, cleaning, playing, and putting clothes on because the mother is not here. But this big sister was very abusive for Lamis. She beating her a lot, and when Lamis complains, she would increasing her punishment. Lamis also have several traumatic events in her childhood. In secondary school, she was in relationship with a boy, whom she loved. He forced her a little to carry on some sexual activities with him. Then he told everybody at the school about it. Students bullied Lamis and avoided her. So every day she cried that she didn't want to go to school until her brother knew from her what has happened. Then he went with her to the school and beating the boy up in front of everybody, that his face and body were bleeding. At this moment, Lamis felt safe, secure, and confident for the first time in her life. But the problem was that the school asked the family to find another place for Lamis and told the president and parents what has happened. And as usual, both the father and mother was beating Lamis severely. And the mother is fighting with the father in front of Lamis and told him that because he has affairs and cheats on the mother, that his daughter is going to grow to become a prostitute, like the woman he knows. And that was too hard on Lamis. At the new school, Lamis met two girls from her old school who abused her and blackmailed her, threatening to show her hell if she doesn't subjugate it to them. That was the beginning of her subjugation. When she told her brother, he supported her emotionally and encouraging her to deal with her friends as they can't take any more problems. After 1 year, her brother died of illness, which broke her as she had no one now to protect her or care for her or doing anything for her. If we're going to how to make a case formulation in schema therapy, we will find the schema therapy is concerned about three basic concepts. First is needs, second, schemas, and moods. In schema therapy, we have 5 categories of needs. The first one is attachment and safety. Second, independent, competence, and identity. The third one is freedom to express your important needs and feelings. Spontaneity, fun, and playing. And the last one is realistic boundaries. People with psychological problems often find it difficult to get these emotional needs met. Early maladaptive schemas. Early maladaptive schemas are self-defeating emotionally and cognitive patterns that begin early in our development and repeat throughout life. Schema modes. This is the concept. It's probably the most difficult part of schema theory to explain because it encompasses many elements. Schema modes are the moment-to-moment emotional states and coping response that we all experience. Often our schema modes are triggers by life situations that we are oversensitive to our emotional patterns. We're using current problems, family of origin, questionnaires, imagery exercise, automatic thoughts from diaries, homework, down arrow technique to identifying schemas and coping styles. If we come back now to Lamise, we will find she has 4 unmet needs. The first one is safety and security. Lamise always saw fragility in her dad and her mom. The second one is validation of emotions. Parents couldn't care less about emotions, which hindered her understanding of her own emotions, hence couldn't express them. There was no room for expressing emotion. It was simply unacceptable and regarded to as ill manners. The third unmet needs was unconditional acceptance and praise. And the last one is guidance and care. If we're going to the maladaptive schemas for Lamise, we will find the effectiveness scheme, which activated in being criticized or rejected by others, or initiating a new project or failure situation. She has also mistrust abuse schema, which activated in working in a new place or starting a new project. Her notable preoccupation with being abused by others in most daily social situation, exposure to any kind of social injustice. The third maladaptive schema with Lamise is emotional deprivation, which activated when she feels lonely when no one calls her, when her sister and mom don't ask her about how she's feeling, when her husband stops sharing what's happening with her. The last 2 schema is categorized like high severity. It's unrelenting standards and emotion inhibition, which apparent in being very harsh on herself. Mistakes are not easily forgiven, and her negative self-talk is her autopilot. No fairly expressing her emotion even with her close friends or family, and keeps it minimum. About schema moods of Lamise, she has child moods like abandoned, lonely, vulnerable, abused child mood, and angry child mood. Her coping mood, it was approval-seeking mood, detached protector, spacing out, and self-soothing mood, and also bullying and attack. Her parents' mood is punitive parent mood. Treatment plan for schema therapy. We have 4 stages of therapy in schema therapy. The first one is awareness of schemas, mood, unmet needs, recent trigger, and how it works. The second stage is building a healthy adult mood to deal with emotion and thoughts. Behavioral pattern change, and the last one is relapse prevention. And we are using 3 categories of techniques: experiential strategies like emotion-focused, limited reparenting, imagery scripting, chair work, and basic confrontation, and cognitive strategy like identify thoughts and emotions, down arrow techniques, cognitive distortion list, Socratic dialogue, advantage and disadvantage, cognitive reconstruction, flashcard, problem-solving training. The last category of our techniques is behavioral strategy, like role-play skills, trying out new behavior, modeling skills training. With Lamise, we have therapy objects. The first object is identifying schema and how they are related to her problems. The second one is decreased feeling of effectiveness appearing in her roles with her daughter, family, husband, and work. The third target for us is dealing with fear and irritable feelings. Last one is deal with unresolved grief and social withdrawal symptoms. The results, it's shown significant change in all of the schemas and moods. And if we're looking for the level of function, we will find it's like progress in occupational and intimate relationship and family relation and social relation and by the end solitary function. Our observation and challenges. In the beginning of the therapy, Lamis was afraid of the limited reparenting technique and of working in an emotion-focused manner. She believed she could not take this kind of closeness with me, her therapist, as she would fear my abandon to her after a while, and then she would have to get out of it by herself. She also initially felt mistrust toward me as I attempted to become close to her, giving her attention and care because her perception of therapy was that it is a harsh, systemized office with no room for human interaction and empathy. After the first 6 sessions in therapy, she grasped the schema approach and looked up the relationship between therapist and the client in schema therapy, hence started to allow herself to get her needs met in therapy. Conclusion, the motivation level of the patient had vital role in her response to the therapy. The limited reparenting techniques and emotional focused therapy increase the bonding into the therapy. Relationship also helps the patient to connect with her unmet needs and the responsibility of this deprivation in her problems. The cognitive techniques helps her to challenge the assumptions and thoughts. The schema therapy programs was very helpful for the patient in decrease her problem. Thank you so much.
Psychotropic drugs and their potential anti-COVID property. Dr. Syed is a colleague of mine in the Faculty of Medicine and Health Sciences. He's a consultant psychiatrist with experience in diagnosing and managing neurodegenerative disorders in later life. He's currently working as an assistant professor of psychiatry at the United Arab Emirates University. He previously had a substantive consultant position in the National Health Services. Dr. Javed has been a member of the Royal College of Psychiatrists since 2011 and holds a master's degree in psychiatry from Cardiff University. His research interest is in carer support and socioeconomic barriers to accessing mental health care. Welcome, Dr. Syed, and we look forward to your presentation.
Thank you very much for joining me at the 7th Abu Dhabi International Mental Health Conference. My name is Dr. Syed Javed. I'm Assistant Professor of Psychiatry at the College of Medicine and Health Sciences, UAE University in Al-Ain. Today, I'll be presenting psychotropic drugs and their potential anti-COVID-19 properties. Special thanks to my co-author for this presentation, Professor Emmanuel Stipp, who is the chair of the Department of Psychiatry at the College of Medicine, UAE University, Al-Ain. There are no disclosures to be made for this presentation. So the learning objectives over next 10 to 15 minutes will include identifying groups of psychotropic medications with anti-COVID characteristics, to list potential therapeutic properties of such psychotropic medications, and to discuss putative mechanism of actions these drugs possess. As we all know, COVID-19 is a severe acute respiratory syndrome in humans that is caused by SARS-associated coronavirus type 2. There is growing evidence for substantive neurological and psychiatric morbidity following COVID-19 infection, with the greatest risk in patients who had severe COVID-19. So our objective was to explore how psychotropic medications work as potential anti-coronavirus agents. We published a piece in Molecular Psychiatry earlier this summer titled as Diversity of Mechanism of Action of Psychotropic Drugs in Their Anti-COVID-19 Properties. This, of course, is not the first time someone has explored the anti-COVID effects of psychotropic medications. Last year, we published a paper in Frontiers Psychiatry on the large action of chlorpromazine, translational and transdisciplinary considerations in the face of COVID-19. For this study, we carried out a targeted literature search by using the names of each drug commonly used in mental health or the class of psychotropic drugs used as keywords. And then we combined those keywords with antiviral, COVID-19, and SARS. The search involved several antidepressants, chlorpromazine as the representative of antipsychotics, lithium for mood stabilizers, and memantine for anti-dementia drugs. Overall, we identified 47 articles with varying levels of evidence, ranging from opinion pieces, review articles, to controlled trials. What we identified that the evidence for mood stabilizers, chlorpromazine, and memantine is still more speculative compared to certain antidepressants. The results described an in vitro action of antidepressants against activity of acid sphingomyelinase, which helps the entry of virus into the host cell. Another possible mechanism of action of psychotropic drugs is affecting cell entry via clathrin-mediated endocytosis, whereas another effect is by modifying the balance between pro and anti-inflammatory cytokines. Now, this is a pictorial representation of various stages at which different drugs act against COVID-19. Now, overall, we managed to identify 14 articles looking at antidepressants activity against COVID-19. Those articles included 1 randomized control trial, 1 non-randomized control or non-controlled trial, 8 preclinical, 3 observational studies, and 1 opinion. Examples of antidepressants included fluoxamine as a sigma-1 receptor agonist, which is an endoplasmic reticulum chaperone protein with various cellular functions that include regulation of cytokine production through its interaction with endoplasmic reticulum stress sensor inositol, requiring enzyme 1-alpha. Clomipramine also showed activity against the Middle East respiratory syndrome coronavirus with no or low cytotoxicity. Less than 30% was the toxicity noted with clomipramine. Another antidepressant, desipramine, was noted to be active against coronavirus genetically engineered human strain, whereas quipazine inhibited viral replication through activity against the SARS main protease, which is essential for viral replication. Moving on to mood stabilizers, looking at lithium specifically, we identified 11 articles. There were no randomized or non-randomized trials. There were 8 opinion pieces or reviews, 2 observational studies, and 1 preclinical study. In terms of potential mechanisms of action for lithium, inhibition of viral RNA polymerase, probably related to blockade of cofactor phosphorylation through inhibition of glycogen synthase kinase 3 beta, projection of host cells from apoptosis triggered by viral infection was another potential mechanism of action noted for lithium, whereas inhibition of nuclear factor kappa light chain enhancer of activated B cells was another mechanism of action postulated for lithium. Interleukin 6 and interleukin 1 beta were also noted to be affected by lithium. Inhibition of IL-6 induced activation of signal transducer and activator of transcription was noted, whereas inhibition of interleukin 1 beta production was another mechanism of action noted to be behind lithium's potential COVID-19, anti-COVID-19 activity. Reduction in cyclooxygenase 2 expression was another hypothesis behind lithium's COVID-19 activity. Now, moving on to antipsychotics. Of course, chlorpromazine has been there for more than half a century now. One of the first antipsychotics to be used clinically, something that was highlighted in one of these papers back in 2020. Looking at chlorpromazine, phenothiazine as the antipsychotic classes, overall we managed to find 16 articles. Again, no randomized or non-randomized trials, 12 opinion pieces, 3 preclinical and 1 observational studies were identified. The main mechanism of action postulated behind chlorpromazine's anti-COVID activity is its activity as inhibitor of clathrin-mediated endocytosis. Also, when seen in mice, it was noted that chlorpromazine increases the concentration of the anti-inflammatory cytokines interleukin-10 and decreases that of pro-inflammatory cytokines, interleukin-6 and TNF-alpha after administration of endotoxin. Carrying on, dopamine antagonism that is caused by antipsychotics enhances blood prolactin levels. Prolactin plays a significant role in adaptive immunity, both at humoral and cellular levels. Prolactin therefore exhibits immunosuppressive response in relatively higher doses under certain conditions. Antiviral activity of phenothiazines might be because of the inhibition of the SARS-CoV main protease, and also the blockage of cell entry pathways used by the COVID-19 virus might be one of the mechanisms behind chlorpromazine's activity as anti-COVID-19 drug. Finally, looking at anti-dementia medications and memantine as a representative, we identified 9 articles, no clinical trials, 8 opinion pieces and reviews, and 1 observational studies was identified. Antagonism of alpha-7 nicotinic acetylcholine receptor and the NMDA receptors may decrease angiotensin converting enzyme to the ACE2 receptor expression and reduce the inflammation. And also, memantine was noted as having a potent protective effect against lesions induced by 6-OSDA in dopaminergic pheochromocytoma cells that are related to reversing nerve growth factor 1B upregulation. Pharmacological inhibition of inotropic NMDA glutamate receptors suppresses neurological symptoms of disease and reduces the expression of pro-inflammatory cytokines in the rat brain. Now, overall, what we identified from our work is that tolerance and safety are vital parameters for drug repurposing to treat or prevent infections with SARS-CoV virus 2. Antidepressants compared to the other classes have a favorable safety profile and are better tolerated generally in older individuals. And one of the advantages of psychotropic drugs is the efficient crossing of the blood-brain barrier and the affinity for synaptic receptors, most of which trigger functions that could interact with the immune system at different levels. So in conclusion, the realization that psychotropic compounds have potentially significant antiviral properties in the context of COVID-19 can improve our understanding of those molecules and also offers a new opportunity for repurposing their role in our pharmacological armamentarium if antiviral characteristics are better characterized in controlled studies. However, a word of caution that it is premature yet to launch a meta-analysis or systematic review because of the number and the heterogeneous nature of clinical studies completed or underway. However, we need to study the diversity of antiviral mechanisms of psychotropic drugs in a translational way. While the current evidence supports a potential anti-COVID-19 role for several antidepressants, chlorpromazine, lithium, and memantine, the level and the strength of evidence remains diverse. These are the list of references used in this presentation and in our paper. And with this, I thank you all and have a good day. Thank you. Bye-bye.
Thank you, Dr. Syed, for this very informative presentation, very interesting findings for a current issue that we are all facing. Now I'm going to introduce myself. I'm the next speaker. My name is Dr. Lina Amiri. I'm an assistant professor at the UAE University in the faculty in the Department of Psychiatry. I coordinate both the clerkship, and I'm a co-coordinator of the behavioral sciences module. My areas of interest is child abuse, ADHD, anxiety disorder, but recently I've been very interested in the current trends observed in the UAE. I welcome you all to listen to my presentation.
Hello, everybody. My name is Dr. Lina Amiri. I'm an assistant professor of psychiatry. I'm actually a child and adolescent psychiatrist at the UAE University Department of Psychiatry. Today, I'm going to talk about a research that I conducted with my colleague, Dr. Syed Javed, who's also an assistant professor of psychiatry at our department. The topic will be, the title of the research is Perception of Beauty and Cosmetic Procedures Among Middle Eastern Youth. I have no disclosures. The learning objectives is to describe the cultural perceptions of beauty in the Middle Eastern population, list personal and societal opinion of cosmetic procedure in the UAE, and discuss the attitudes as an exploratory approach to generate further hypotheses and help professionals devise cosmetic treatment strategy that reflects current trends in the Middle Eastern young population. Before I start, let me give you some background information regarding this research topic. I've always been fascinated about beauty and the concept of beauty and what I see as beautiful versus what others see as beautiful in terms of features, body type, and everything related. As a young girl, I remember my grandmother talking about how hook nose was considered beautiful in the woman population, and she didn't have a hook nose, and she used to use a clothespin to pull her nose down in order to fit the current trend. And I think since then I've been like watching and seeing how people perceive beauty. And as you know, and as you can see around you in the UAE, especially where I live around Al Wasl Road, there are so many cosmetic clinics around. There is the cosmetic surgery clinics, the derma clinic that offer cosmetic procedures, and the dental clinics that emphasize the cosmetic side of it. So these clinics must have a great population, otherwise they will not exist in abundance like they do right now. And hence this idea of this research. I was wondering what kind of people attracted to this kind of procedures, who allows it, who pays for it, how do society perceive it, how do opposite sexes perceive it onto each other. All of these questions made me think of a research idea that will address some of them for now, and we'll continue to explore it further later on. Cosmetic procedures contend with the preservation, rejuvenation, and enhancement of the physical appearance through surgical or therapeutic interventions. About a third of individuals who undergo cosmetic procedures are under the age of 35. Despite an evident surge in interest towards cosmetic procedure, there is a paucity of research exploring the subject in the Middle East. And this was very evident when we were preparing for this research. The objectives: with a transforming society deeply rooted in tradition, the UAE can be used as a representative of the Middle East. Here we explore cultural perceptions of beauty and how these relate to personal and societal opinions of cosmetic procedures in the UAE. Now going on to methods. we disseminated an online self-administered survey comprising of 63 questions to university students in the UAE. We targeted this population only. The survey was designed to evaluate youth attitude pertaining to cosmetic procedures and delineate their personal experiences of undergoing these procedures if applicable. These are the top 5 procedures that were considered cosmetic from the survey: tooth luminaire, nose reshaping, facelift, nose reshaping with medical reason, like septum deviation, and chemical peel. Let's now talk about the results. 178 participants responded to the survey with a response rate of 35.6%. 91% of the participants were female and 58 of them were aged 19 to 21. Even though most participants had never sought cosmetic intervention, a majority, 63% of them, felt these procedures are gaining acceptance in the UAE culture and society. 48 of the participants felt the idea of men having cosmetic procedures is frowned upon in the UAE culture, against only 10% in the case of women. Nearly 70% of the participants felt that a legal and regulatory framework was essential to determine the permissible age for undergoing cosmetic surgery. This is vital because the number of people you see walking around having undergone obvious cosmetic intervention are the younger population, and sometimes I wonder how young they are. So it's interesting that people are asking for that. Majority, 65%, opined that the hourglass body shape is the most beautiful, with 2/3 of the participants indicating that pale, white, and light skin was the most beautiful in terms of complexion color. The aquiline nose, which I'll show you in the next slide, was deemed as the most beautiful by the majority of participants. That was 43.8%. And just 1.7 participants viewed as hook nose, which I referred to earlier, as attractive. This, to my personal opinion, was not what I expected. I expected the upturned nose, which I see commonly around as a form of a pattern that I see in rhinoplasty here in the Middle East, is the most common shape they transform into. But the aquiline, which is the third in the top shapes of nose, is the one that they perceived as the most attractive. Now, moving on to discussion, from an anthropological perspective, it is beneficial to view the body as a reflection for society and vice versa, that is always changing and evolving with time. Techniques and habits related to beauty, such as cosmetic procedures, are constructed by culture, and therefore there is a relational connection. In today's world, beauty has become a tool to improve the quality of life in general, a mean to surpass the physical and relation problems of an individual. It is sought after by both gender and is not limited to a specific age group. The concept of beauty, the ideal face and body form, is often shaped by the media, within advertisements, subliminal messages, and social media, which is something that people are always referring to as a guidance. Many women with natural dark complexion believe that fair skin makes them more appealing, attractive, and successful, suggesting that skin whitening products relate to primal instincts. Surgical procedures such as cleft repair have been identified in the past to increase confidence and quality of life, but these are medically indicated interventions. However, things that are considered cosmetic, like liposuction, show no conclusive evidence on the benefits of it onto the confidence of the person. The likelihood of men being judged and frowned upon for undergoing cosmetic procedures is much higher than women in the Middle East, and more specifically here, which is not surprising. This finding is arguably related to the traditional notion of the role of men in the Middle Eastern society and the cultural concept of beauty. The shift from traditional masculinity has been explained by post-industrial work pattern changes, ideologies of technology consumption, and change in gender relations. In conclusion, cosmetic procedures are increasingly being accepted among youth in the UAE, with skin and nasal procedure being the most popular. The youth concept of ideal body shape is in alignment with the Western ideas of beauty. Further research could characterize these perceptions in other cultures and explore differences in what is perceived as beautiful in various parts of the world. The following are my references, and I'm happy to answer any questions you may have. Thank you very much for listening.
Thank you very Okay, thank you very much for attending this session. I don't see any questions that have been directed to us here. So please feel free to reach out if you have any questions in the future that you think about. And it was a pleasure to have you in the audience. Thank you very much.
Hello, everyone. Today I'm going to be talking about allodoxophobia and atychiphobia, particularly in obstetric emergency management. My name is Dr. Tracy Roke, and I'm Head of Education and Student Affairs. I also work at Natal Emirate Hospital. This is the hospital that I work at. Isn't it quite beautiful? It's a women and children's hospital, and it has a north and south tower in Abu Dhabi, UAE. So this presentation is about two particular phobias, being atychiphobia and allodoxophobia. And it's particularly in relationship to obstetric emergencies, but it's also relevant for all other emergencies where they do have team training. So what exactly is atychiphobia? Well, very simply put, atychiphobia is a fear of failure. Now, this phobia is experienced by a majority of us in one way or another, and may not, some may not necessarily experience it, but it's a kind of phobia that can actually go from mild to extreme. It's also linked with quite a few anxiety and mood disorders, and that affects some, or particularly people's mental health and their quality of life. So here's a few signs of what can cause the fear of failure. So we can have the avoidance, anxiety, feeling helpless, feeling powerless, indecisive, and also feeling out of control. Now, I have highlighted avoidance, and this is something that we will re-look at a little bit later in the presentation. So what exactly is allodoxophobia now? Well, allodoxophobia is when someone has fear of other people's opinions. They're scared of being ridiculed, and it might even be someone stronger that might not be agreeing, making them look like a fool. And it is, funny enough, quite a common phenomenon. And it's been known to impact all of us at some time or other. But this phobia that we're talking about today is particularly related to emergency situations where you see a constant habit-forming practice that goes through. So how does the mind actually respond in emergencies? So what causes atychiphobia and allodoxophobia in emergencies? So the causes are actually the real thing. We need to first of all look at the causes, the behaviors, and what we can actually do to resolve this issue. So it is a thought pattern that one will be ridiculed, or the fear of that one will be failing, particularly during emergency. So for instance, let's give you a scenario. There is a consultant, an anesthesiologist, and now we're going to be demonstrating a code blue drill. Now this anesthesiologist is an expert, and he should know exactly how to use an AED, for instance. And then the drill starts going on, but he has just arrived from another hospital. He hasn't actually been trained on the new AED, and then he looks like he doesn't know what he's doing because he can't operate the AED. Or there might be a consultant obstetrician, and she's been asked to do bimanual compression. and yet she's not really happy or comfortable with doing it, because in another hospital, they don't do it that often. They rather send the woman off to theatre, whatever it might be, and she doesn't do it as well as she can. These are just some common things that could possibly happen. So it really is a fear that the team may criticize behaviors or actions, especially if actions were not performed at the level of expectation. Now, if one doesn't have the training itself, you wouldn't be aware of how debriefing occurs. So within a debriefing scenario, we are not allowed to do any blame and shame. So it's a very kind, gentle place where people can make mistakes without a negative criticism, but rather a team approach and how we can actually improve outcomes. And this is why I love the PROM course, which is Practical Obstetric Multi-Professional Training, because we actually taught about the fact that mutual respect is so important, highlighting that. And it's okay if we make mistakes, because when we make mistakes or we fail, we actually do better next time. So what can we actually do to help dissipate these fears? It's really important that we consider this. Now, remember, I put that picture in the first few slides, avoidance. Now, this is one of the common things what we notice is that when you try to start doing training on the units and people don't get involved, I particularly start to question, why is it that they don't want to be involved? Okay, obviously there's a workload and all that things happening, but at the same time, you see a constant a pattern happening. And I know about this pattern because I used to be part of it. I used to have a fear that people were looking, oh, she's a midwife, but she doesn't know how to do that. So I used to go and hide quickly in the toilet or do whatever I could not to actually get involved in the actual training itself until I became an instructor and became normal for me. Then I actually realized, well, actually I could pick up the areas where people were actually practicing avoidance. So we need to understand the psychological hormone responses that happen in our body, physiological. We also need to understand the insufficient effect of irregular training. When we don't have enough regular training, it actually can cause, you can have another fear, which is a fright and flight fear, which I'll explain a bit later. And then, of course, the avoidance, worrying about what people think. So there is a thing where people do dread doing training, particularly drill scenarios. And the reason being is that there's a psychological thought pattern behind it and also physiological thought pattern behind it. So the first is psychological, is that we question and doubt our own abilities to function in an emergency. So we don't really trust ourselves, our knowledge, how we're going to work. Because of the high intensive adrenaline that's happening, sometimes we don't think very clearly, right? Particularly if you're not doing drills on a regular basis, this can happen. It's like you telling me to do a conference to a bunch of cardiologists on the effect of norepinephrine on the body, and there's 1,000 people. I'm going to really go into a fright and flight situation, right? My body will respond very differently. But if I had to do that same presentation for every day for a week, by the 7th day, I'll absolutely feel fine and normal. And this is exactly what we're trying to get through, that the more people practice, these particular feelings that they get, these anxieties, will actually dissipate. We're also scared that we won't know how to do the task. Therefore, we pretend that we know how to do it. So there's a couple of things that people do. They either pretend they can do something, they hope they can do something, or they think they can do something. And when you either pretend, hope, think, this causes substandard care. So it's always important to know that substandard care is anything below 100%. So it's always important to exceed your intentions or to exceed your abilities so that you can actually prevent any substandard care from happening. We are scared that we might frustrate or even anger the team if we don't do tasks properly. And we're also scared that we might lose respect. And the team will talk about us in a negative context, destroying our reputations. So the fright and flight response is very, very simple and very clear. So first of all, the stress causes the sympathetic nervous system to actually signals to the adrenal medulla. The adrenal medulla releases catecholamines into the bloodstream, so pumps them out, boom, 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 boom. And then it causes a fight or flight response. And this has a multiple body part reaction. So we have a situation where the epinephrine is pumping out, estrogen, norepinephrine, dopamine, testosterone, cortisol, and serotonin as well. And this is actually causes like absolute overwhelming reaction. Now, the freeze response that can happen due to hyperarousal is when the muscles get tense, full of energy, but they just can't release it. So there's a pumped amount of all these hormones in the body, but they just can't be released. And also almost like a catatonic response. And then you get the freeze regarded to the shutdown or the collapsed. For instance, like the cat holding the rat. The rat is now feeling hyper-aroused. The muscles are flaccid and loose and therefore cannot run away. So this is a very, very, it's a last ditch, it's a survival tactic, funny enough, and the body can actually not get out of it. So the perfect scenario would be, for instance, you hear about stories that people have done superhuman things, picked up cars, and when they've been in a situation where they rushed, or even if they've been chased after a big bull like this, they've managed to even jump over fences and things that they normally wouldn't be able to do. So endorphin and adrenaline would actually help with this task, and it actually helps there's been quite a few reports about superhuman tasks because of this huge rush, and it causes the flight response. Another example is when we get an overwhelming amount of adrenaline and stop the flow of endorphins and oxytocin, which can result in a stored labor, and this is a safety response. For instance, a buck might be in the environment where there's a lot of predators around, like in South Africa. It's just about to give birth, it's in labor, and then suddenly it sees a predator, a lion or whoever. It will literally stop its labor because of the endorphins. Oxytocin will stop, and the adrenaline will start to work. The buck will stop its labor, it will manage to run away to a safe place and then continue to give birth. So with the fright and flight response, this is what happens. The eyes start to dilate. People start to breathe a little bit quicker. The food movement starts to slow down. Blood vessels tend to dilate. Muscles become tense. Stomach issues go on. Our heart tends to beat a bit faster and harder. You might get a little bit of a restriction with chills and sweats, and even the saliva might start to decrease. Well, yeah, and this can be quite a common thing, particularly speaking at big international conferences like today. People get a bit anxious about it, and this is absolutely normal. But as I said, if you had to do it more and more often, all of these symptoms will dissipate, and that anxiety will go. So we spoke about the heartbeats, the pupils, the breathing rhythm, how the stomach can actually clench, and all this, their sexual hormone wake-ups. So how we cope may be very different from each other. But however, there is some things that we need to know that all colleagues feel the same way. There is some time in life where we've actually, whether it was being a student or even a qualified consultant or whoever specialist, that we feel the same way. And that we are all professional. We do not gossip about each other, and we're here to learn. And practice certainly does make improvements. And when we practice, these phobias can be controlled. So this is another little graphic on the flight or fight. So you see the fighting kind of thing where they've utilized the overwhelming amount of hormones in the system now to actually get on with it. And then another one where they've literally ran away because they can't cope. So it's an automatic nervous system that has two components, the sympathetic nervous system and the parasympathetic nervous system. So the sympathetic nervous system functions like a gas pedal, really, or a petrol pedal, and in a car. So it triggers a fight or flight response, providing the body with a burst of energy so that it can respond to perceived dangers. So the psychological traps, as being involved in a life-threatening situation, can literally be quite terrifying. So in obstetric emergencies, it is a life, we are in a life-saving situation, and it's all up to me now as a team leader or whatever to actually now make sure that this patient is, the outcomes are good. People under severe stress are not always able to think clearly, and they can actually make the wrong decisions. And we've actually at Natal formulated some wonderful tools that it can actually help with that. We've made performers which will clearly dictate the steps that are needed. And these performers are also handy for documentation. So the team leader no longer needs to think about the policy, but they've got the beautiful little cheat sheets in front of them. Okay, have we done this? Have we done that? Whatever. And it's a beautiful way of actually making sure that all of the steps are completed, because we understand that adrenaline is incredibly powerful. And when one practices in a safe environment, like using simulation and having a policy of mutual respect, these phobias certainly can diminish. And I know it even for myself, how I've actually helped to diminish my phobias. We can't just rely on the annual prom course or whatever it might be, or your BLS course that you do every 2 years. But I certainly do believe that performing drills on a regular basis in the units, testing systems can actually help dissipate and make all those fears go, that it becomes a norm, that you can think clearly and actually practice in the real emergency when that actually does arrive. So we really look at, there's something that we just don't want to, we want to illuminate medicine. We want to make sure that we don't have any failure in the structure. We want to make sure that things are a lot user-friendly and easy to use, and not to complicate things at all. So I did highlight a couple of these elements, but I'm just going to quickly, briefly go through them. The way that we can reduce fear of failure particularly is the no shame policy, addressing the problem, learn from mistakes, try not to bottle it up. And this is when it's good with the debrief, discussing either after the real emergency or when you're busy doing training. To actually look and start questioning your own fears and your own anxieties, and be truthful and transparent with yourself, and focusing on what you can control, and also embrace the gray, which is, shouldn't be seen as black or white, but rather actually, success is something that's should be honored, really. So in conclusion, failure is a stepping stone to achievement. So first of all, we have to understand that a fear of failure, when you have failure, it's a stepping stone that you're moving forward in a direction, a positive direction to achievement. It helps one learn from one's mistakes, can also be a main ingredient on moving forward in one's career. Rising from failure is a sign of progress as well. And when we learn and take new steps in achieving our dreams, it helps us to achieve our dreams. So training and practice in a safe environment will elevate these symptoms and reduce phobias. Allodoxophobia and atikiphobia can bring a positive or negative result in someone's life, depending how it really is managed. So some people develop a standard close to perfection and or strive to excellence since they're afraid to fail. These people are referred to as perfectionist or compulsive disorders. So really, it's important that we understand that fear kills more dreams than failure ever will. These are my references, and it was an absolute delight speaking to you today or this evening. So thank you so much for engaging. Have a good day.
I don't have any disclosure to that, and the objective is to maybe to recall some elements, some feature about this symptom, this syndrome, which is called catatonia, which is a complex phenomenology with an evolutive nosographic position from the German classification to now the DSM-5, for instance. We will review some clinical features, and we will find what is the best, treatment considering the guidelines and the knowledge, which is renewing now. So it's a behavioral syndrome marked by an inability to move normally, and which can occur in the context of many psychiatric and general medical conditions. But it has to be, presented as an emergency sometimes, and usually it shows good responses to benzo or to more in severe case in ECT treatment. And however, failure to recognize and properly treat catatonia can lead to poor outcomes, and there is some malignant catatonia which occur, which can be fatal. So it's nice to have a recall of that. So it's marked by an inability to move normally. It's marked by heterogeneous signs that are observed or elicited. And the most common are immobility, rigidity, mutism, posturing, excessive motor activities, sometimes with like a very dangerous movement, stupor, negativism, staring, and echolalia. So it can be associated with different medical conditions. One of the main findings now is with the receptor and MDA antibodies encephalitis. Some other autoimmune diseases, schizophrenia is still a main occurrence with catatonia, with 35% of the case from catatonia. Can be found usually in bipolar disorder and many other mental disorders such as substance-related disorders, some metabolic disturbances, and focal neurologic lesions, and sometimes drug abuse. It's now classified in a specific way in the DSM-5 because it's a specifier. So you can have a diagnosis, for instance, schizophrenia, or you can have a bipolar disorder or a depression, and you have to specify that there is a new feature, which is catatonia, and different codes are proposed for that in different aspects of the association between a psychiatric diagnosis and disorder, which is completely related to catatonia. So I don't give the detail for the DSM-5, you can find that in your manual, but it's surprising to see that there is a huge variability in the prevalence of catatonia depending on the country, etc. But it's not disappearing. I remember my students talking about catatonia, and they consider that as a historical aspect of psychiatry, but sometimes we can find catatonia at the emergency. Sometimes we are called in certain words for giving an assessment for a very specific patient, and we are establishing easily catatonia syndrome. So how many catatonia have you seen in your career? It's difficult to answer, but it's underreported. According to Kruger, current prevalence of the catatonia in Europe, for instance, would be from 7 to 15% of the psychiatric admissions. So it's huge. Medical reporting a higher frequency in India compared with Europe and to North America. So it's not uncommon in India. It was created by Carl Ludwig Kahlbaum, who published the monography on the catatonia, oder das Spannungsreisen, and it describes the symptoms with 17 signs, and since this time it's still valid. The complications of catatonia can be very serious because it can lead to thrombosis, to bed sore, to nutritional deficiency, and sometimes, unfortunately, to death. There is some challenge state that we can use, for instance, in the context of an emergency unit. You can try lorazepam, you can try zolpidem, and you have some other treatment. But the best way to test that is to use lorazepam, but with a high dosage. It's not 2 or 4 milligrams. Usually you go over 10, 20 milligrams. And zolpidem also, which is a very good medication for challenging the catatonia, and you can resolve the syndrome very easily with this kind of 2 medication. And the other are sometimes used. ECT treatment is still a good indication and a good treatment for serious catatonia syndrome. There are many case reports. It can be found in some guidelines, for instance, in mood disorder or bipolar disorder, and sometimes in schizophrenia. And it is very effective to many patients with catatonia. So do not hesitate to use it. If it's appropriate, you can have a beneficial effect, even for adolescents with catatonia schizophrenia. We have a lot of citation in the literature about catatonia in ECT, and there is a description of treatment. There are some guidelines for using and describing the protocol for the ECT in catatonia, but it's always used in a very severe patient condition, and it could save the life of several patients. So obviously there are historical images in psychiatry which count for catatonia to describe the different aspects of the history of psychiatry. And usually it's linked to very bizarre posture and very bizarre inflexibility. It's called flexibility cirrhosis, for instance, so waxy flexibility. And students are not aware that it could still be seen in some contemporary patients in emergency in some wards. And I was surprised because I was called in on my hospital in Canada, and there was a person who was completely mutism, very stiff, and the basic lab was normal, ECT was quite normal. There was something, but not related to the syndrome. And he was a 43-year-old man, and I called my student and I put the patient with different position, and he stayed in this position for many long minutes, showing that flexibility, waxy flexibility is still present when we try to find it in several patients. So do not hesitate to keep on this kind of a clinical exam to precise your diagnosis with this kind of patients. So I would like to describe this patient because it's good, it's easy in story, and the evolution is in good relation to what with the contemporary treatment that we can propose to this very severe patient. And we receive a lot of treatment. Every psychotropic drugs were tried on him, and he was referred to us to second advice and to see if there is an alternative treatment for him. So he was unable to move. Sometimes he stayed in this position, for instance, for 20 minutes, sometimes 1 hour. When I met him, he was admitted in our unit, and we were not able to, even after 1 hour to 2 hours, to see another position in these patients. The medical history was quite complex, and he has a complex partial epilepsy, bitemporal shown in EEG. He has hypertension, 2 trials of clozapine for refractory schizophrenia, and that was stopped because he had seizures 2 times, and the PET scan was normal on this patient. So he was presenting schizophrenia with many signs of catatonia, sometimes very severe periods of paranoid schizophrenia with delusional disorder, persecutory themes, or erotomaniac type themes. And he was treated with many antipsychotic drugs, and the team before we referred the patient tried a lot of time ECT treatment because it was refractory and dangerous for many people. He became outpatient several times, and he had many falls, hospitalization, many hospitalizations in different hospitals and in institutes, but difficulty to treat. He received a lot of ECT, more than 200, I think. And it was in the context of aggressivity and catatonia, very severe syndrome. When we admitted the patient, he was on different treatment with valproic acid, chlorpromazine, olanzapine, difenilide. It was, you know, the historical feature of his medication was very broad, and we collected maybe more than 20 or 30 medications during this evolution. So what we received the information. One of my colleagues asked Dr. Steve, can we treat the patient because he received too many ECT? We are not able to stop the ECT. He received ECT every 2 weeks because catatonia and aggressiveness when we stop the ECT, and so it's maintenance therapy. But now we have too many ECT sessions in his life, and he's quite stable about psychosis, but we cannot keep on to put this patient in ECT after 300 ECT treatment. What could be the alternative? There was always a risk of malignant neurological syndrome, and the Bush scale was high. Bush scale is used as a catatonia scale. It was very high at 41. So that was the treatment we gave at the admission, with some anti-epileptic drugs and amisulpride as a main treatment for his schizophrenia. So we proposed to alternate ECT because it was, impossible to keep on, imagine a patient, a refractory patient, with more than 300 or 500 ECT treatment in his life, all the damage in the brain. So we tried to propose an alternative, proposing RTMS treatment. So we defined the parameters with the localization in frontal lobe and with a specific frequency, and the patient agreed, and the team was ready to begin. So we tried the treatment every week with specific locations, 5 centimeters anterior and parasagittal to the point of the dorsolateral prefrontal cortex. We use DLPFC stimulation, 20 Hertz, and 3,000 stimulation at 100% of the motor threshold. And I don't know if you can see here, but after the session of RTMS, he was still unable to walk, walking well, able to have a better functioning, and we maintain the treatment every week, twice a week, and we stop completely the ECT treatment. So this is a graph showing the evolution. There was sometimes a score with the Bush-Francis catatonia scale, which showed that the patient is not completely cured. He has some, but the goal was to avoid to keep on the treatment with ECT, which is not a good treatment for a person who has epileptic features, schizophrenia, and who is very sensitive to every brain alteration with this kind of treatment. So the conclusion of this treatment was no more ECT. So that was a good picture. The next step, because we found that the brain stimulation is beneficial, the EEG were normalized, outpatient setting found, inconvenient autonomy, repeated session of RTMS, transportation. So we asked to the ethical institutional board if we can, instead of putting the patient with the RTMS treatment every or twice a week, if we can implant something just around the brain. So we proposed to a 4-contact paddle electrode implanted in the dura mater over the DLF-PFC through small craniotomies and under neural navigation to ensure the accurate placement of bilateral epidural cortical stimulators on the DLF-PC over the posterior half and the mid-frontal gyrus. That was a localization which was decided by a multidisciplinary team, including neurologic and neurosurgeon, nurse, and the ethical board. So we applied a stimulation, and I would like just to describe the evolution of this patient. So he went to surgery with our team, and we were able to, you see on this scan, to see where we wanted to place the electrodes. So it's under the scalp, so that just in front of the dura mater. And we placed two paddles with 4 electrodes, and we were able to manage the stimulation instead of putting the patient every day or twice a week to the RTMS. So that was the surgery. And at the end, we were able to manage the stimulation with a pacemaker, which was placed in the thorax, close from his shoulder, and the patient became able by himself to place, in front of his pacemaker a measurement, and we were able to control, to see with him which would be the correct stimulation to have impulse in his brain instead of RTMS. So this is, one of the first trial to avoid a patient to keep on an ECT treatment during the whole life after more than 500 ECT treatment. And it was the first clinical use of epidural stimulation in catatonia. Of course, there was meeting with family, with the ethical board, and we were a multidisciplinary team with a nurse, social worker, and the patient was able to go out the institution, the psychiatric institute, and he was able to have a follow-up with the team as usual, with a general practitioner. And since now 5 years, he didn't have any more ECT. He's still on antipsychotic drugs, and he is able to communicate with us. Of course, there is a lot of sequelae of the ECT treatment, of the bad evolution of the schizophrenia syndrome, with the refractory case and resistance to every medications, and his life was not very easy, and but we are still in touch with him, and we have a good relationship with him. But he still have some difficulties in his life, of course. But I think that was a good example with this kind of syndrome, which is sometimes ignored, to give alternative treatment to ECT when it's a refractory condition. So thank you very much for attending to this presentation. So it was an illustration with the case of the evolution of our thought about catatonia treatment for very severe patients, but we merit all the attention of the team in mental health. Thank you.
Okay, hello everybody. So are there any for the presentation on allodoxophobia and aticophobia? Anything at all? Hi team, it doesn't look like anyone would like to ask any questions for the time being, but they're welcome to put it in the chat box or later.
Good afternoon. Good afternoon, everyone. It's our pleasure to present today our session of psychodermatology. First of all, we'd like to thank the organizer for this opportunity. To the best of our knowledge, this is the first time during the psychiatric conference in Congress, psychodermatology session has been organized. I'd like to thanks to those of you who are attending here, and in the same time to thank all of people around the world who are attending in front of their screen and interesting for this. Before to start first presentation, allow me just to say few introductory words. Psychodermatology is still considered as an emerging subspecialty, but in fact what is emerging is the recognition of that field. Otherwise, it exists and often exists as medicine. This is the area of medicine where dermatology, psychiatry, and psychology overlap each other. We have mainly two groups of patients. First is those with primary psychiatric condition who have dermatological changes and search for help from dermatologists like delusional parasitosis and dermatitis artifacta. And the second group are the people with skin problem who might develop or usually develop psychological deviation. For example, those with eczema or psoriasis who after that have anxiety and depression. So what is first and what is second is controversial and questionable, like the theme for egg and chicken. But anyhow, those patients need help from all of us together, from mental health specialists and dermatologists. I would like to say something also for psychodermatology clinic, which is usually a place where dermatologists and psychiatrists, psychologists sitting together. However, I am afraid that if I want to make full introduction, there will be no time for our talk. For that reason, I'll proceed with the first talk, which is stigmatization in dermatology. We have no conflict of interest. Dear colleagues, the advances of medical science enrich our knowledge and understanding about diseases and their process, and pharmaceutical industry brought new, more effective medication that changed the life of 1,000 patients with skin disease. Yet, patients with skin condition experience various psychological comorbidities. They've been increasingly recognized and more research has been performed, mostly on the condition as a depression and anxiety, but some other also including suicidality. However, today I bring your attention to stigmatization, the problem we believe not receive enough attention, not only on medical community in general, but also from researchers. Originally, the Greek word stigma meant the mark of pointed instrument, but its meaning and connotation have been varying considerably over the century, obtaining even religious character in certain period of time. Nowadays, stigma is defined as a discrediting mark, biological or social, that set a person off from others and disrupt interaction with them. Stereotyping, distrust, fear, or avoidance are all forms stigma can take. Stigmatization begins when individuals with discrediting mark are marked by another individuals or groups. So those individuals become label carrier of the mark they carry. At present, health-related stigma has been classified in three main groups. The author studying leishmaniasis suggests new category, aesthetic stigma. We, with Professor Zhypiatovsky, after performing our research on stigmatized psoriasis patients in UK, we'd like to suggest also the term iatrogenic stigma. I'll be happy after talk to discuss with some of you who are interested how we reached to this conclusion. The medical field recognizes a number of diseases, the sufferers which are stigmatized, and certain skin conditions are among them. Skin conditions, especially in regards to their aesthetic aspect, are frequently the reason of social rejection. This has a negative influence on the personal and social life of the patient. Skin plays an important role in establishing interpersonal relationship and thus cutaneous disorder, which have a significant impact on physical appearance, influence other people's attitude. Our own research found that stigmatization has been studied in 20 different dermatological conditions, unfortunately very limited in most of them. As you can see, just 1, 3, maximum 3 articles exist. We found that psoriasis was the most studied condition. Almost 1/3 of the literature which was found studied stigmatization in psoriatic patients. Entire study has been published, is available free on the internet. The visibility of skin lesion and the role of the cultural factor are actually the main one that playing a role in stigmatization process. And here, I'd like to bring to your attention some example. It was found that patients with fingernail onychomycosis experience greater stigmatization comparing with those with toenail onychomycosis. In the study analyzing stigmatization experience in patients with hidradenitis suppurativa, result from the 6-item stigmatization scale demonstrated that disease involvement in exposed skin area play a crucial role in the level of stigmatization. Patients with rosacea were also evaluated, and the result indicated that the visibility of symptom was certainly a factor explaining stigmatization process among these people. The attitude to people with skin problem can vary in different countries and culture. In certain culture, the fear of stigmatization due to skin disorder can be really devastating. In an article about cutaneous leishmaniasis in Pakistan and Afghanistan, the author commented on the common practice to isolate affected people during the course of active lesion. They reported that usually parents isolate their children from others, including their siblings and even themselves. Moreover, women with this disease are considered not eligible for marriage and even not accepted by their own family. Despite the disease is treatable, the disfigurement and social stigmatization may become the reason for psychological disturbance and may even associated with high risk of psychiatric disorder. Another article from Nigeria reports that 2 girls with lamellar ichthyosis has been hidden since they was born. Yes, they was hidden from entire society, from relatives, from neighbors. Why that happened? Such family are considered as outcast or having bad genes, and for that reason, marriage to any member of such family is not encouraged. It was clearly underlined that to protect the future of other children, the girls were kept in isolation and denied any education. Consecutively, they were existing with no chance in future employment and no normal life. Cultural factors and visibility of skin lesion cannot be separated and cannot be analyzed individually. I'd like to bring to your attention the result of 2 studies performed with the same protocol, the same design, and the same measurement instrument, but in 2 different countries. The first was in Europe, Poland, and the second study was performed in United Arab Emirates, Abu Dhabi. In the first study, authors found surprisingly that face had no influence on the patient feeling of stigmatization. At the same time, our study in Abu Dhabi multivariate analysis revealed that involvement of face is a very important factor. Those differences, we believe, can be explained with cultural factors. Our research found also numerous instruments used by different groups in different conditions. We classify them as dermatology-specific and disease-specific. To the best of our knowledge, this is the first attempt to identify in group questionnaire for stigmatization assessment in patients suffering from different skin disease. All those questionnaire and instrument has been published also online. Similar signposts and posters might be seen mostly related to mental health problems. Recently, also some dermatological conference, especially psoriasis. Unfortunately, no worldwide accepted program to address this problem. The difficulties that exist are available now. I would like to note that some effort have been done and few proposed suggestions have been made. Unfortunately, because of restriction of time, I cannot explain in detail all this suggestion, project, and work of some small group. If you allow me to conclude, stigmatization in dermatology appear to be important problem. The two main factors that contribute to stigmatization are visibility of skin lesion and cultural factors, and the result indicate that psoriasis is most common disease where that's been studied. Several different instruments were used to evaluate stigmatization level by different research groups, which limit the possibility to make a direct comparison between the study. Dear colleagues, despite the advances of medical science and pharmaceutical industry, thousands of dermatological patients carry every day the severe burden of being stigmatized. There is no worldwide accepted program aiming to help those affected by stigmatization. Call for holistic approach can be heard very often. We believe such approach has to include anti-stigmatization program for our stigmatized dermatological patient. Thank you very much for your attention. I'd like to invite Dr. Rim Al-Niadi for second talk. Dr. Rim is a dermatology resident in SKMC Abu Dhabi, and she has also interest to psychodermatology. So she presents one of our case in the clinic.
So thank you, doctor, for the introduction. So I'll be presenting a rare case of drug-induced delusion of shrimp infestation. So our patient is an 84-year-old gentleman who was brought into our dermatology clinic by his family with the main complaint of irritation and stinging sensation around his fingertips. And over the 9 months, he has gradually progressed into seeing shrimps coming out from the same area under his nails and fingertips. This preoccupation has been worsening and affecting his family's quality of life and his quality of life in a negative way. The patient is not able to sleep at night, he does not get out in the morning, and he's always preoccupied with catching these shrimps. Finally, the family was distraught enough to bring him in to seek medical attention for this problem. So reviewing the patient's medical history, he is known to have diabetes mellitus, dyslipidemia, peripheral vascular disease, coronary artery disease, and atrial fibrillation. As for family history, he has a dead brother who had a mental illness, but it was not known to us what was the illness. So clinically, he had periangle erosions from his attempts to catch the shrimps. There are multiple crusting and erosions of various sizes from the manipulation. This is just a picture to resemble what the patient had. This is not the patient. He was actually trying to catch the shrimps during the talk or during the visit in our clinic. So as for personal history, the patient was married with 7 children. He is currently retired but used to be a leader of a political group. He was described by his son as a very strong man with a strong personality. He currently lives with his daughter, and his sons occasionally come and visit, but he prefers to sit alone most of the time. He is able to walk, but 2 years ago he had surgery for chronic back pain, so then he stopped walking by choice and he became wheelchair dependent. So because of his hallucination and these symptoms, we consulted our psychiatry colleagues regarding these issues, and based on their assessment, he is described as having constant low mood that is associated with crying spells at least once a month. He is also feels like his life is worthless, he wishes to die, he says, I don't want to wake up tomorrow, but he has no suicidal thoughts nor plans to do so. His son also reports deterioration of short-term memory. He forgets if he prayed or not. He repeats the same questions. He forgets recent conversation he had with his family. And as for cognitive function, he's not able to appreciate the difference between large and small notes anymore. However, he is cooperative, he is calm, he has preserved language, he is oriented to time and place. Okay, so based on the presentation, our initial assessment was delusion of infestation, and in order to make the diagnosis, we must rule out secondary causes like medications. And because of this list of comorbidities, he is expected to be a polypharmacy patient, and he was on this list of medication. And upon detailed review of this list, it came to our attention that 3 of these medications are known to cause hallucination as a side effect, including metoprolol, clopidogrel, and esomeprazole. So our plan was to stop these medications and to see if the patient improves or not. But before, we have to have the primary doctor on board with us before stopping these medications. So to have an overview of the patient, we have 9 months of tactile and visual hallucination. And the patient was diagnosed with primary delusion of infestation by psychiatry, and antipsychotic aripiprazole was prescribed. However, the family refused for him to start on it. So aiming to rule out drugs as a secondary cause, esomeprazole was stopped first, and after some discussion with the doctors involved with his care, and they agreed on stopping it, there was no change with his symptoms. So the next drug to be considered was stopping clopidogrel, and it was a challenge to stop in the light of his cardiac condition, until finally one of the cardiologists who was familiar with the side effect agreed to stop it. So within 2 weeks, the family reported the symptoms improving. He did not mention the shrimps anymore as much as he used to, and he became more, he didn't mention them as frequently as he did. Unfortunately, due to the COVID pandemic, he lost follow-up because our hospital became a COVID hospital, so they went to another hospital. And 4 months later, we received a call from his son saying that there is reoccurrence of the shrimp hallucination. And when we reviewed the medication again, it coincided with him resuming the clopidogrel under a different brand name. So this, when we knew that he restarted again, this confirmed the suspected causality, which is the clopidogrel at that point. So esomeprazole is a proton pump inhibitor. It is used for the gastric reflux. This is a report of all reported side effects, and hallucination was one of them. The next medication is metoprolol, which is a beta blocker. It is naturally a lipophilic medication, so it can cross the blood-brain barrier, which explains the hallucination. This is a case series of 3 patients who developed hallucinations from starting metoprolol. And finally, to the best of our knowledge, clopidogrel-induced hallucination has only been reported twice in the literature. And comparing them to our patient, these patients developed symptoms within days of starting the medication, whereas our patient has been on it for many months. And these patients had visual and auditory hallucinations. Our patient had tactile and visual hallucination. So in conclusion, with this case, we aim to raise awareness regarding the diagnosis of delusion of infestation, which is the fixed, false, unshakable belief that the person is infested by a living or inanimate pathogen, despite the lack of medical evidence of such infestation. So secondary causes of hallucination must be ruled out, like medication, tumors, or infections, before making the diagnosis of primary delusion of infestation. And the rare side effects of clopidogrel as a potential cause of hallucination should be noted, especially since a lot of the elderly populations are on these medications. And most importantly, interspecialty collaboration is needed to achieve the best patient care and management. We couldn't have stopped the medication without the help of the primary doctors and with them agreeing on stopping these medications. Thank you for your attention.
Thank you, Dr. Rim. We'll keep all questions for the end of the session. We expect eventually to have some question from online participant. The next case I'd like to present, we work together with Dr. Medhat on that patient. Dr. Medhat is, for those who don't know, is the chair of the conference. He is working as a psychiatrist, consultant psychiatrist in SKMC Abu Dhabi. We have no conflict of interest. We are presenting under the name dysesthetic syndrome. In the literature, you can find also other name, is a trichodynia also. However, we prefer to keep this terminology as a more wide term. Dysesthesia, and the meaning of dysesthesia is abnormal sensation. Its etymology comes from the Greek word dys, means not normal, and esthesia, which means sensations. Various definitions can be found in medical literature. Here is some of them. However, the patient reported that sensation is usually as a burning, tingling, itching. Some of them even describe as electrical jaws. But less often, it's reported as a frank pain. Independent of patient complaints, all cases are characterized with the absence of objective dermatological finding. We'd like to present a 45-year-old female patient attended to our dermatology clinic with complaints from pain over her skin on the temporoparietal scalp. The patient complained also from hair loss. Physical examination did not reveal visible changes over the entire scalp. There was no any rash, no pupil on pimples. There was no crest or scale or any other primary or secondary dermatological lesion. There was no even secondary excoriation. The examination didn't find any area of the scalp without hair or with a reduction of hair density. There was no other health problem that may explain the above symptom as well. However, detailed history ascertained that patient experienced psychological problems. After discussion, she admitted to be seen by psychiatrist. So here you know already who was the psychiatrist. During the psychiatric consultation, patient revealed that 7 months earlier experienced excessive hair falling and later on developed feeling of sadness, increased appetite, poor sleep, and excessive thinking of death, feeling that life is not worth living, but no suicidal thoughts. Based on this psychiatric consultation, a diagnosis of major depressive disorder and anxiety were made. Treatment with bromazepam 1.5 milligram per oral at bedtime and paroxetine extended release 25 milligram was prescribed. Within next 3 weeks, the patient reported feeling better regarding the scalp pain as well as her mood, self-expression, and sleep. After 8 weeks, the medicine was kept only on her paroxetine, and 8 months later has been stopped. At present, patient have no any complaint and no medicine. Scalp dysesthesia is a chronic cutaneous pain syndrome and may have severe negative impact on patient quality of life. A relationship between scalp dysesthesia and cervical spine abnormality have been described. However, no such changes was found in our patient. The relationship between scalp dysesthesia and underlying psychiatric condition is also well established. During the psychiatric consultation, our patient was diagnosed with major depressive disorder and anxiety. Those findings corresponding with previous report describing persistent depression, generalized anxiety, and somatization is a most commonly associated condition with scalp dysesthesia. Most of the cases describing scalp dysesthesia reported treatment with antidepressant and usually utilized tricyclic ones. Our patient received paroxetine in addition to bromazepam. With this case, we'd like to stress on the importance of proper psychological assessment. Those case was presented as a poster during the biannual Congress of European Society for Dermatology and Psychiatry. Here, I'd like to invite all of you to visit the website of this organization, European Society for Dermatology and Psychiatry, and eventually, if some of you have interest to become a member, this is the biggest of the world association where dermatologists, psychiatrists, and psychologists sitting together to help the patient with those problems. Thank you very much for your attention. Here I'd like to invite Dr. Mariam for the next talk. Dr. Mariam is a dermatology resident in SKMC Abu Dhabi, and apart of interest to general dermatology, she also has interest to psychodermatological patients. Please, Dr. Mariam.
Thank you, Doctor. Good afternoon, everybody. It's a pleasure to be here. Today I'll be discussing a case that highlights the importance of adequate psychodermatological knowledge in dermatologists and how this can affect the management plan of patients dramatically. So the case that I'll be presenting, I saw it with Dr. Dimitri, my mentor in our psychodermatology clinic. It is a 50-year-old female known to have diabetes and hyperlipidemia. She was referred to our psychodermatology clinic with the diagnosis of dermatitis artifacta and delusional infestation after being seen in several dermatology clinics. Okay, so I will briefly say the definition of delusional infestation again. So it is when the patient is, in other words, it's when the patient is 100% convinced that there is a living organism on or under their skin. And the second diagnosis she was given is dermatitis artifacta, which is a form of factitious disorder. And when the patient is fully aware and is, they're the ones who produce their skin lesions, and usually they hide the fact that they produce their skin lesions from the physician. Those patients usually like to play the sick role and have a psychiatric background. So these are the two diagnoses our patient was given. We took further history. So our patient was complaining of a chronic itch, stinging and burning sensation over her extremities, her arms and her legs. She admitted that the lesions were produced by herself as a result of severe itchiness leading to bleeding at some points. So on examination, she had some crusts, excoriations, some erosions on her skin, which are all a sign of self-inflicted traumatization. In fact, when our patient was given the diagnosis and informed her family, this had a negative impact on her life, as our patient was fully aware of her surroundings. It affected her self-confidence, how her relationship was with her family and her friends. We did a psychological assessment for our patient, and the combined result was that she had mild anxiety and borderline depression. And her dermatology life index score showed a small effect on the patient's life. We did further assessment, and it was found that her diabetes was uncontrolled. In fact, she developed long-standing complications of diabetes like retinopathy and neuropathy. Her HbA1c was 9, which is poorly controlled. So combining the history and the examination that was done, the diagnosis of dysesthesia syndrome was made. And as Dr. Dimitri mentioned earlier, dysesthesia is a sensation that patients usually describe as burning, squeezing, prickling sensation, and most of the time it is because of nerve damage. In our case, our patient's nerve damage was due to her long-standing neuropathy because of diabetes. So how did we manage our patient? We started her on duloxetine 30 milligrams twice a day, and after 1 month, her symptoms improved by 80%. Patient lost follow-up and came back to us because her symptoms recurred, and when she was started on treatment again, her symptoms were controlled. We are following her up now by teleconsultations. Patient is doing well and back on her medication. In this case, I hope I emphasize the importance of psychodermatological knowledge among dermatologists in order to not only how misdiagnosis could wrongly direct the management plan, but it can also lead to stigmatization of the patient. And in our case, our patient was fully aware of her surroundings, which mentally affected her. These are my resources, and thank you very much. Dr. Dimitri? Thank you.
Thank you, Dr. Mariam. I also want to emphasize that presented case with the fact how is important non-psychiatry physician to have knowledge about psychiatry. I believe that it's very important, and always insist to my colleagues and friends psychiatrists that all of us who are not on mental field, not on mental health field, we need to attend some specially prepared lecture of psychiatry for non-psychiatrists that can be really of great help for us eventually when we're helping our patient. I'll continue with the next talk, but it was, I want to share with you that was a challenge for us how exactly to prepare this session. Finally, we decided to have a few short and small talks on different topics instead of having one or two big talks. On the next one, I would like to speak about the problem which is usually not discussed among dermatologists, the problem about suicidality. Not because dermatologists don't know that suicidality exists, but somehow this topic is not discussed. This talk we prepared together with Dr. Williams, who is consultant dermatologist in Devon Hospital in England. On behalf of her, I also would like to thank the organizer and all of you being here and in front of your screen now. As mostly of you know, the suicidality accounts for approximately 1 million deaths per year, and suicidality is the second reason for death in the second and third decade. Articles regarding suicidality among dermatological patients have been published. However, this problem remains somehow out of the main dermatological highway. Suicide is an act performed by an individual with the knowledge and expectation of its fatal outcome. Suicidality itself includes suicide ideation, thinking about, considering and planning suicide, suicide attempt, a non-fatal, self-directed, potentially injured behavior with the intent to die, and unfortunately complete suicide. Without intention to discuss the risk factor in detail, I would like to bring your attention to the fact that 95% have a mental health issue and to stress on the importance of psychological assessment of patients with chronic skin condition, especially the one with chronic condition. According to the present understanding, various factors play a role. Suicidality has been studied in skin condition, however, not in numerous ones. Large multi-center study conducted in 13 European countries found increased suicide ideation among dermatology outpatients. Our search on PubMed with Dr. Williams using term suicidality and the name of different skin condition found numerous articles. However, after detailed checking, we found that many not related or also there was high duplication. It seems the most common condition where suicidality were studied are psoriasis, atopic dermatitis, and acne. The result of numerous studies suggested that patients with psoriasis are in increased risk for suicide. The researcher found the unadjusted incidence of suicidality 0.9 per 1,000 person year, while in control group was only 0.66. Study published last year examined the rate of suicidal behavior for untreated mild, moderate, and severe psoriasis expressed by 1,000 patients year. When compared to mild psoriasis, only severe psoriasis was associated with high risk of suicidal behavior. However, meta-analysis of observational studies reported conflicting results. Some not association and other increased risk of suicidality ideation and behavior. Obviously, more research on that field is needed. Atopic dermatitis seemed to be the skin condition where suicidality were mostly studied among young population. Data from 72,000 adolescents were analyzed. Students self-reported atopic dermatitis and yes or no answer about the suicidality. The researchers compared adolescents with and without atopic dermatitis. Those with atopic dermatitis were significantly more likely to experience suicidal behavior. In the multivariate model, the relationship between atopic dermatitis and suicidal behavior were statistically significant. Here I would like to bring to your attention two examples. Suicide ideation among males with atopic dermatitis, almost 16% compared with 13%. And suicide attempt among female with atopic dermatitis, 7.7 versus only 5.3. Another study examined suicide ideation among parents of children with atopic dermatitis and found high prevalence not only of suicide, but please note also on homicide ideation among the mother and father of those children. A higher degree of suicide ideation has been ascertained among adolescents with acne. Survey of New Zealand examining acne, anxiety, depression, and suicide in teenagers found that suicide ideation was 22% and attempt 5.2%. In comparison, only among adolescents with acne, the suicidal ideation was almost double, 40%, and attempt more than twice. In a pilot study, psychiatric comorbidities, including suicide probability in adolescents with acne, were also evaluated. The mean score of suicide probability scale were found to be higher in adolescents with acne. Psychiatric comorbidities were significantly higher in adolescents with acne. Also, self-injurious behavior were higher. All of the above is suggestive that young people with acne are in increased risk of psychiatric comorbidity, including suicidality, and psychiatric assessment should be included. Please note, such assessment is important also to detect of any potential covert sexual abuse. The death of 4 young males affected by alopecia areata recorded by the coroner as a suicide, 2 of boys aged 14, 1 16, 1 17. All 4 boys have been recently diagnosed with multifocal alopecia on the scalp. There were no preceding psychological disorder, and all of them were capable students. Social withdrawal and school avoidance begin after diagnosis of alopecia. Another article described a 14-year-old girl with ecchymosis on her face, head, and neck. She described the lesion as painful, but was more distressed by their appearance. No pathology found on hematological investigation. Detailed history revealed that the patient derived no pleasure from life and having thoughts of death and suicidal ideation. Body dysmorphic disorder is well known with extreme high suicide rate. The high rate of lifetime suicidal ideation and attempt among adolescents are in fact significantly higher in comparison with affected adults. Suicidality was studied among patients with Sturge-Weber syndrome also. The researcher concluded that those patients might be in greater risk for suicide. Another study found direct correlation between the size of birthmark and depression. Erythromelalgia, the condition not very common, I don't know how familiar non-dermatologists with this condition, has been reported in relation with suicidality, not only among adults, but also among adolescents. A case of Munchausen by proxy, which is child abuse, has been described with subsequent suicide of the mother. Myths about suicidality. Unfortunately, they exist. They exist not only among the general population, but also among us, the healthcare provider. I'd like to bring your attention and to comment on the third one about asking people, since that also overlap with assessment and eventual prevention of suicidality. Talking about suicide does not put the idea in the head of the patient. Rather, the assessment may provide relief by opening an avenue for discussion and giving opportunity to feel understood. In asking about suicidal ideas, it's helpful to begin with mild question, addressing the patient's feeling about living, such as how do you feel emotionally? If the patient expresses feeling of sadness, hopelessness, you may further ask with additional questions such as, have you ever felt that life was not worth living? If the response reflects dissatisfaction with life, should ask further questions to elicit details about specific plan for suicide and any step that have been taken. In doing so, please maintain an empathic and non-judgmental attitude. If suicide risk is present, further assessment should address the eminence behavior. Make yourself familiar with the guidelines as well as collaboration with the local mental health authority. In order to help with the identification of eventual suicide, well-established and validated tool under the formal questionnaire exists. Depression screening questionnaire can be utilized, of course, but also specific asking for a suicide tool exists. Well, I'm sure most of you recognize the Golden Gate Bridge, San Francisco, California. The scenery is really beautiful, especially if you're watching during the sunset. Unfortunately, the bridge has sinister history also. Since it has been built in 1937, more than 1,500 suicides has been recorded. The research of 25 people who survived brings some information to us. Suicide people are ambivalent. This gives us opportunity to save life. According to the medical research of those who survive, show that when they try to suicide, actually they don't want to die. They just want pain to stop. If you allow me, instead of conclusion, greater awareness of the prevalence, clinical presentation symptom, utilization of better screening tool, and greater interspecialty collaboration, especially all of us non-mental health have to collaborate with mental health colleagues. All of this may lead to earlier, more effective intervention. Thank you very much for your kind attention. Thank you very much for your interest. I noticed that when session started was only 4 people and now is more than 10. However, we have limited time. We have one talk. I would like to invite Dr. Sarah. After presenting a few cases, Dr. Sarah will speak about treatment, which are applying in our clinic, and he will present few cases in relation with that treatment. Dr. Sarah is a resident in dermatology, second year, but a part of general dermatology, she also has great interest to say psychodermatology. Please, Dr. Sarah, welcome.
Okay, thank you, Dr. Dimitri. Thank you, everyone. So I'll be discussing habit reversal therapy. So what is habit reversal therapy? So this is, it's also called habit reversal training. It's a behavioral modification technique. It was initially developed for patients who had tics and other nervous habits, but it was later adapted into help patients manage the scratching associated with atopic dermatitis. And atopic dermatitis is kind of an umbrella term for eczema and eczema-like disorders. It does have other uses in dermatology. I've listed only a few. Acne excoriae, so this is a condition where patients have mild acne, but they end up picking or excoriating their acne. Trichotillomania, which is a disorder where patients pull at hair-bearing areas, so scalp or eyebrows or eyelashes. Onychophagia is the biting of the nails. So how it works in atopic dermatitis, so patients with eczema already have a disrupted skin barrier. So they lack some of the nutrients, or they lack some of the proteins that people regularly have in their skin. So because of this compromised skin barrier, they get irritants, allergens enter the skin, they develop an itching sensation, they scratch this itch, and then it's called the itch-scratch cycle. So it goes on and on. And initially the itch is more localized, or sorry, the scratching is more localized, it's in one area, but later becomes like a habit that they itch all over, it's kind of unconscious, they just keep doing it. So our goal, why we don't want them to scratch is because it disrupts their sleep. If it's a young patient, this is going to disrupt school. It's going to disturb people going to work in the morning. Also, scratching the skin creates little wounds. That creates entry ports for bacteria, and it's not healthy. So our goal here is just to have them replace scratching with a more desirable behavior so that their skin can heal. So in eczema, we usually use the combined approach. So we use emollients or creams or moisturizers, then a prescription cream, either a steroid or a steroid-sparing agent, and we combine it with the habit reversal or behavioral modification. So these are our cases. Like Dr. Dimitri said, we all practice out of Sheikh Khalifa Medical City in Abu Dhabi. So the first case is an 18-year-old young lady with onychophagia dermatotillomania. So she's biting her nails and she's picking the skin around her nails. So we tried to manage her with the topical treatments, steroids, topical antibiotics for infection, but it didn't work because she kept biting and picking at her nails. As part of evaluation for some of these patients, we had her fill out some screening questionnaires and offered her a visit with a mental health specialist, but she declined the referral, was keen on trying habit reversal therapy, and she had really good results. The photo on the left, she actually provided to us. It's not her, but this is what she said her nails looked the most similar to. The photo on the right is her nails after she'd done habit reversal therapy with the topical treatments for some time. So you can see at the end, she doesn't have a nail. It still hasn't grown out from all the times she's bitten and picked it, but all the wounds that she would have had around her finger have healed quite nicely. The second case is a 6-year-old with chronic eczema, and so she was always itching and had kind of thickened skin on her elbows, her knees. So we treated her the traditional medical way with steroid creams and emollients and added habit reversal therapy, and she had a really good response. Third case is a 14-year-old with trichotillomania. Like the first case, the topical therapy didn't help because the underlying behavior kept going. Also declined a visit with a mental health specialist and had good response with habit reversal. So trichotillomania is when they rub at hair-bearing areas, causing the hair to fall out. Trichotillomania is pulling and trichotillomania is rubbing. There's other terms like trichodagnomania, where they're biting the hair, trichorexomania, where they're using their nails to cut their hair, trichotillomania, people have compulsive cutting of hair by scissors or shavers. So how do we do habit reversal? First of all, we need to select an appropriate patient. So this needs to be someone who acknowledges that they have a behavior that they want to change, and someone who's motivated and can do the treatment at home. Then we start with registration. So here we don't ask them to stop the behavior, we just want to make them more conscious of it. So we tell them to note down how many times this behavior takes place at home. Sometimes patients like using a clicker, sometimes they just write it down. And then to note down what they're doing when this behavior takes place. So if they notice when they're watching TV, they're engaging in this behavior a lot, that might be a good idea for them to keep themselves busy while they're watching TV. This is filled out by the young lady in the first case who, with the nail biting and nail picking. So she noticed that when she was writing down, she became more aware of when she was engaging in this behavior the most. These two forms were filled out about a month apart, and she hadn't stopped completely, but she'd significantly decreased it. She'd realized when her hands were idle, when she was watching TV or just studying or doing an online class, her hands were free. That's when she would pick at her nails. So this is why, so she now started to distract herself at that time or keep her hands busy. So how do they do it? There's different techniques. The most common one is to tell the patient when they develop the urge to pull or to bite or to scratch is to gently clench their fist for 30 seconds. And this is usually referred to as the claws to paws technique. So a cat that wants to scratch has their claws out, but a cat that's more gentle has their claw or nails inwards. And pause also doubles as pause, as in take a second to pause and think. They can also fix the arms at the sides of their body or gently pinch or press the area that's bothering them until the impulse or urge to scratch or pick is gone. They can also use fidget spinners, Rubik's Cube, squeeze toys, but this can be quite difficult for patients who are in school or children at school because they can't take these into the classroom with them. So it's helpful if they know one of the backup techniques. And this is the patient from the second case with the chronic eczema, and she's sharing her feedback with habit reversal. If I can please have help with the video.
From dermatology clinic and Khalifa Hospital suggested me a technique in order to reduce my scratching. This method was that you have to think 3 seconds before you scratch. Also, another part of this technique was that you have to write down on scratch each day. When you think for 3 seconds, it makes the urge of scratching less. Everyone around me noticed my improvement and were very happy. This technique made me be more conscious of my actions and made my scratching reduce. Thanks for watching. Bye! Hello, my name
So to summarize, registration, noting down the behavior, instruction, making the change, and then follow up. And then it's important for them to have a good support system at home, especially children. We know, especially children who have eczema, who are scratching, that there's a reason why they're scratching. So we advise parents to avoid negative phrases like stop, don't do that, and instead, or like threatening to take away toys or the iPad, and instead encourage them to use their fidget spinners or to write down that they're doing this behavior, or use sticker charts, reward charts. And habit reversal is being more described in the literature. It was looked at during the COVID-19 pandemic as a way to decrease hand-to-face touching. It was compared to object manipulation training for nail biting and found to be slightly more effective, and looked at in the treatment of OCD. And this is a good resource for patients. It's very patient-friendly. It has a lot of colorful charts and diagrams, and these are actually where we got the forms from. So take-home points, it's a successful technique, but it takes time and it needs to be done on the right patient. And it's important for your patient to have a good support system at home that can help maintain this at home, the changes at home. Thank you.
Thank you. Thank you very much, Dr. Sarah. I just would like to add the habit reversal for patient with different dermatological condition is usually not a method which is recommended to be used alone. It's part of the combined method, but for one or other reason, those 3 cases either refuse or was very busy to apply their medicine, so we get the great result only as a mono treatment. And the girl which you saw in the video, to the best of my knowledge, is the busiest person of the planet. She's going in school, going on ballet, going to hockey and drawing. And according to the parents, participate in all family activities. She is first morning wake up and last one who is going to sleep. And she was one of our first patients for habit reversal. I would say in the process of establishing the psychodermatology clinic, we was almost established when the COVID started and everything has been stopped, and we now somehow going back. And I would like to use this stage to make call for those of you who are eventually interested for some collaboration in future. We will be very happy whatever we can make together, some work, a study or workshop or presentation, whatever you can feel might be beneficial for our patient. We'll be really happy to do. So we'll be happy now to take questions from the room or from people who are watching us online. Thank you very much. The question was in general for 3 or especially for the girl? Yes, yes. What we found actually that this 3 patient was very motivated. The period was approximately between 2.5 and 3 months. But we not consider this as a rule. We consider this as the best result. We not expect that to happen with every patient. Please. Yes.
Thank you very much for the collection of cases that you presented today. It was very interesting, especially for us psychiatrists to see this being presented and these kind of patients presenting to dermatology, maybe first or second. I just had a question or a couple of questions about the stigmatization. You mentioned that you noticed that mostly it was related to whether it was on the face or not. I was also wondering if there was a relation between if they were female or male. Did that show any difference in how stigmatized they felt with their conditions? That was my first question. And then the second question is regarding, I think it was the first case, the 84-year-old gentleman with hallucinations. I was wondering if dementia was ruled out fully for him, because some demented or dementia cases present with originally hallucinations. And the last question is about depression or suicide with dermatological diseases. Do you think that it is showing a comorbidity? Like, is it reactionary depression to their the condition that they have, or could it be something that's part of the disease?
Right.
Yeah, these are my three questions. Thanks.
Well, thank you. Thank you so much. Let me try to start. First, it was about stigmatization. Yes, the study was performed for 120 patients approximately. The statistical analysis didn't show such difference between female and male. What was interesting for us, it was not expected that the difference from result in Europe, and as I mentioned, to explain with the cultural factors. The second question was about the gentleman with that we call Schrems delusion. So I personally believe that there was but there was no consultation with psychiatrists before that. Mostly health problem of the gentleman was cardiological. When we call for psychiatric consultation, as Dr. Arim mentioned, and psychiatrists advice for starting antipsychotic, that make family not happy and they didn't want to continue relation with psychiatrists. For that reason, he was not totally assessed and proper diagnosis to be made. Anyhow, I think that dementia should be on the list of diagnosis. And the third question was about?
Whether depression is a comorbidity with these dermatological disorders that was leading to suicide, or could it be part of the, the disease?
Yes. This question was always been discussed on our psychodermatological meeting. And there is no one opinion between experts. However, maybe the dominant opinion that should be considered case by case. I'd like to thank you for your few words when we mentioned that we're bringing such cases here who is coming to dermatology. Actually, this is one of the reasons psychodermatology to be more and more recognized. Many patients with different psychological mental health problem, for one or other reason, they're coming to dermatology, and then despite being referral to mental health specialists, refuse that, going to next dermatologist, so-called doctor shopping process is going on. And this is one of is because only stigma or other factors also playing role. If I can share with you, a few years ago with Dr. Medhat, we make a small, I would not say even study-like experiment. I offered those patients to have psychological assessment on the telephone from my room, from dermatology, and most of them was agree. And when I further asked, most of them was happy to see psychiatrists in dermatology clinic, but not to go to psychiatric clinic. So this is one of the base, actually, psychodermatology clinic to exist. And usually where dermatologists and psychiatrists sitting together, but not in psychiatric clinic, in dermatology. Any other question, please? Yes?
Thank you very much for your talk. I wanted to ask you, again, on the same lines we just said, because I've had a couple of patients with similar presentation, the nails biting and OCD, obsessively they're scratching the skin and on face. So once you treat the OCD or you treat the anxiety disorder, apparently, the skin improves, dramatically. So, it's good to kind of consider working together, but I've seen it the other way around too, like patients who do not have the psychiatric stigma. And what's your thought on that? Like, have you had cases or, where OCD?
Thank
because
you.
I've had at least 2 cases that come to my mind.
Thank you. Suddenly habit reversal will not treat the OCD. So that's why everything should start with proper assessment and, if necessary, involvement of mental health specialists. We can have habit reversal. We can help somehow habit to be treated, but certainly will require also either psychopharmacological or psychological treatment for the patient. So it certainly will not be enough. I don't know if I answered to your question. Thank you.
Hi, thank you for a very interesting session. What you're trying to emphasize is the need for collaboration between psychiatrists and dermatologists. I'll go a little bit more higher. I think we need to have collaboration with all specialties.
Well, thank you.
In fact, there is a need for liaison psychiatrists in this region, really.
Thank you very much. By the way, we have such in SKMC Abu Dhabi. We have liaison psychiatrists. Unfortunately, one person cannot cover the same time all areas.
We need psycho-obstetrician, psycho-gynecology, psychosurgery.
Well, I believe. Yeah. I believe all specialty need psychological help. As I discussed with some of you, if I try to refer patient to cardiology, urology, whatever specialty, there is no problem. But if I try to refer to mental health, here we go.
Right. Exactly. We need better collaboration, definitely.
Thank you very much. Once we have collaboration, if there is will, we'll find a way. Thank you so much. So if no other question, allow me to close the session. But I hope with closing this will open other door for further collaboration. Please, our contacts are on the brochure, or always you can find us. The easier way is just dermatology in SKMC. We'll be very happy to be contacted and to have some further activity. Thank you very much for your presence here. Thank you.
So welcome to this session about understandings of recovery and recovery-oriented services in a Norwegian context. We are 4 people working at the Center for Mental Health and Substance Abuse, and we are Mona Sommer, Trude Klevan, Bengt Karlsson, whom you'll all meet later on, and my name is Marit Borg. So what we'd like to share with you in this session is the following. So first an introduction by me, then we're going to have a TED talk by Bengt Karlsson about recovery as living with mental health issues. And a TED talk, if you haven't heard about that before, is a short, focused way of spreading ideas. And this is going to be in Norwegian, so you have to put on your subtitles in English when you start looking at this. Afterwards, Trude Klevan is going to talk about dynamics of recovery, followed up by Mona Sommer, who is talking about living life, recovery as processual experiences. And at the end, there will be a few minutes for discussions and reflections. So briefly about the Center for Mental Health and Substance Abuse. Our research center was established in 2010. We are a multidisciplinary research team and we have broad clinical experiences both within the children, adolescents, adults and old people's age groups. We emphasize collaborative research and also peer research. And our research priorities are as followed: recovery and recovery-oriented practices, dialogical and collaborative practices, child and adolescence issues, and collaborative research in partnership with clinical practice, or practice. And by practice, we mean service users, family members, clinicians, local policy development people, and managers. So we try to develop our research project together with a broad community. Recovery orientation in Norway has roots within the user and carer involvement in central policy documents and practice developments since the 1980s. I would say that we've been trying to draw on the lived experience of service users and also the lived experiences of community living if you have struggles in your life. And recovery perspectives and practices was in many ways a natural follow-up by these central policy and practice developments. And in Scandinavia, recovery has from the very beginning had a contextual and social basis as much as the personal process. And when it comes to focus on recovery-oriented practices, we again have developed these with inspiration from service users, user organizations, and community development. So it's helped us to have to raise attention to issues like living conditions, a person's meanings and hopes for a meaningful life in the community, activity and work, and also human rights. Some of the challenges when it comes to recovery-oriented practices and recovery orientation in general is the needed reorientation of the knowledge base. Because as many of us know, the recovery perspective typically challenge the individualistic and biomedical traditions and thinking. And it also challenges the treatment, some of the treatment guidelines, ways of organizing our services, the partnerships involved in recovery orientation, and also outcome measures and evaluation. So when it comes to recovery research at our research center, initially I would say that recovery in research in general in Norway has been growing since around 2000. And at our center we have been focusing on the personal and social aspects of recovery, also on implications for services, and finally, peer support and peer support work. And recovery research has been given priority in our research proposals, in PhD thesis, in master thesis, in books and book chapter we've written, and also in numerous scientific publications, as we'll come back to later on. And in the presentation today, we'll first start with a critical discussion of recovery through the TED Talk by Bengt Karlsson. And this is followed by two meta-syntheses drawing on our recovery research during these years. So Trude will first talk about the dynamics of recovery, and then Mona will talk about living life, recovery as processual experiences.
Livet skjørt. Vi kan alle bli rammet av psykiske helseutfordringer. Hva gjør jeg da? Skal jeg holde det for meg selv, av frykt for å bli stigmatisert, få en psykiatrisk diagnose og måtte ta medisiner? Eller skal jeg tørre å søke hjelp i omgivelsene mine? Hvordan skal jeg komme meg og leve med de utfordringene jeg har? Se nå for deg Grete. Hun har en lederstilling, gift, sosialt aktiv og deltar i ulike fellesskap med venner og i organisasjoner. Plutselig braker alt sammen. Grete blir skilt, hun blir sykemeldt, venner slutter å ta kontakt med henne og går forbi uten å hilse. Hun isolerer seg og klarer ikke å delta i ulike sosiale fellesskap. Grete søker hjelp for sine psykiske helsevansker. Hun får en diagnose, tilbud om psykofarmaka og en liste over privatpraktiserende terapeuter som hun kan ringe til. Disse har 1 års ventetid. Grete gir opp og går ikke lenger ut blant andre mennesker. Eksempelet viser at forholdet mellom Grete som person og hennes livssituasjon er avgjørende og en del av det å leve. I det du opplever psykiske helseutfordringer som begrenser deg, starter arbeidet med å finne ut hvordan du skal leve med disse utfordringene. Hva skal til av praktiske og følelsesmessige forhold som gjør at du kan leve med det du opplever som krevende? Psykiske helsevansker er verdens største folkehelseproblem. FN slår fast dette i 3 ulike rapporter. De skriver at mennesker som opplever psykiske helsevansker har, sitat, blitt utsatt for utelukkelse, forsømmelse, tvang og misbruk, og forstått som avvikende fra gjeldende kulturelle, sosiale og politiske normer. Sitat slutt. Rapportene slår fast at den psykiatriske modellen er utdatert og må erstattes. Det er behov for et paradigmeskifte, ifølge FN. Så hva er de konkrete problemene med den psykiatriske modellen? For det første så tjener legemiddelindustrien store penger på psykofarmaka. Inntektene er årlig på hundrevis av millioner av kroner ved salg og bruk av disse medisinene. De har ofte liten effekt og store skadevirkninger. Medisiner er også ofte det eneste behandlingstilbudet som blir gitt til personer med psykiske helsevansker. For det andre er det skeive maktforhold i psykisk helsefeltet. Psykiatere og psykologer er de som sitter på toppen av pyramiden av fagfolk. De har makt til å forvalte sannheten om hva som er den beste og riktige behandlingen for de som har psykiske vansker. Videre lytter fagfolk generelt i alt for liten grad til hva brukerne selv mener. Hjelpen blir ofte bestemt uten at brukerne har noe å si eller får medvirke. Mange brukere har egne erfaringer om hva slags hjelp som har vært hjelpsom tidligere. Dette bør fagfolk lytte til i mye større grad. Det er også et problem at fagfolk ikke retter søkelys på brukernes levevilkår, sosiale forhold og menneskerettigheter. Hjelpen blir heller individualisert. Det betyr at hjelpen tar utgangspunkt i at det er noe feil inne i personen, og det blir ikke undersøkt hvordan sosiale, økonomiske og relasjonelle forhold påvirker personens psykiske helse. For det tredje mangler det lokale tilbud og lett tilgjengelig hjelp. Vi trenger åpne sosiale møteplasser med lav terskel hvor alle er hjertelig velkommen. Det kan være lokale treffsteder med kafé og muligheter for å delta i aktiviteter som turgåing, musikk, trening, lesergruppe og mer. De som faktisk bruker treffstedene bør bestemme hva som skal være av aktiviteter og tilbud. FN-rapportene peker også på økende sosiale forskjeller som den viktigste årsaken til at folk opplever psykiske vansker i vår tid. Det å leve med lite mat, lite penger, uten arbeid eller bolig, i ensomhet og fysisk isolasjon, skaper psykisk helsevansker både i vårt land og i verden for øvrig. Sosial utjevning, likhet og rettferdighet er de viktigste bidragene til å skape forandring, ifølge FN. Gitt at den psykiatriske modellen og dens tilnærming for å håndtere psykisk uhelse er utdatert, hva skal vi da gjøre? Det er da recovery kommer inn. Recovery kan oversettes til å komme seg etter psykiske vansker og klare å leve med dem. Recovery handler om oss som personer og de livsbetingelsene vi lever under. Recovery er opprør mot å bli møtt og behandlet som syk og upålitelig. Personer som opplever psykiske vansker skal ikke behandles i psykiatriske institusjoner gjennom sykeliggjøring og overmedisinering. Når mennesker er i psykiatriske institusjoner, ser vi bare en liten del av dem. Hvordan kan vi forstå personens psykiske vansker når vedkommende er langt vekke fra venner, familie, arbeid og alt som er kjent? Recovery som begrep og bevegelse startet på 1960-tallet som en del av den amerikanske borgerrettsbevegelsen. Kravet var at alle borgere i USA skulle ha de samme rettighetene og mulighetene. Denne kampen inkluderte også personer som opplevde psykiske vansker. Bevegelsen The Psychiatric Survivor Movement kjempet for overlevelse og mot undertrykkelse, mot sosial stigmatisering og utstøtelse, og ble en del av borgerrettsbevegelsen. De dokumenterte omfattende overgrep, tvangsbruk og overmedisinering mot innbyggere med psykiske vansker. Tilsvarende kamper og bevegelser foregikk også i andre vestlige land med de samme kravene om like rettigheter, muligheter, sosial og politisk, juridisk og menneskelig trygghet og respekt. I dag er recovery fortsatt et opprør mot å bli stemplet, marginalisert, sosialt ekskludert, fordi man opplever psykiske vansker. For det første, recovery innebærer å utfordre psykiatrisk kunnskap og behandling gjennom diagnoser og kategoriseringer. For det andre, recovery handler om å synliggjøre og gjøre noe med de krenkelser og den urett som mennesker med psykiske vansker har opplevd, både som enkeltpersoner og som gruppe, i familier, i lokalmiljøer, tjenester og i samfunnet. For det tredje, recovery har frigjørende krefter og kan forløse mot og handling hos personer. For det fjerde, recovery skaper fellesskap som gir muligheter til å leve med de utfordringer som livet byr på. Som mennesker blir vi født inn i relasjoner, vi lever i relasjoner, og vi dør i relasjoner. Og det er ikke antallet relasjoner vi inngår i som er avgjørende, det er kvaliteten på relasjonen. Det er faktisk tilstrekkelig for personer som har opplevd psykiske vansker å ha en sterk og god relasjon til en annen person, for selv å ha det godt. Det kan være en venn, en kjæreste eller en psykisk helsearbeider. Vår psykiske helse leves ut i våre relasjoner til familie, venner, arbeid, økonomi, bolig og samfunn. Like viktig inngår vi i relasjoner også til dyr, natur, kultur, nabolag og samfunn. Det er viktig for vår psykiske helse at vi har et hjem. Ikke bare et sted å bo, men noe vi kan kalle et hjem. Et sted jeg kan lukke døren, føle meg trygg, vite at her hører jeg hjemme. Mange studier viser at det å ha et hjem er helt avgjørende i recovery. Å inngå i livets ulike relasjoner handler om å inngå i fellesskap. lettere lytter fagfolk. førersetet. Fagpersoner og andre skal støtte personen i dette arbeidet. Alle som ønsker å hjelpe, skal gå ved siden av personen, ikke foran. Det kan være venner, familie, kollegaer, fagfolk og naboer. Når det gjelder utvikling av recovery-orienterte tjenester, skjer dette i samarbeid mellom brukere, pårørende, fagpersoner, ledere og beslutningstagere. Minst like viktig er at vi hele tiden må vurdere om våre recovery-praksiser, våre recovery-baserte tjenester, innebærer det beste og det frigjørende i recovery-tradisjonen. Vi må se til at recovery-tjenestene ikke blir tilpasset slik at alt bare fortsetter som før, slik det alltid har vært gjort. Oppsummert, som mennesker står vi sterkest sammen. Mennesker trenger mennesker.
Hello, my name is Trude Klevan. In this part of our presentation, I will share with you the findings and some implications of a metasynthesis exploring dynamics of recovery. But before moving on to that, I will very briefly describe the background for doing our metasynthesis and how we worked when conducting them. So why do a metasynthesis in the first place? As Marit Borg elaborated on earlier, researchers at the Center for Mental Health and Substance Abuse have conducted an extensive number of qualitative studies for the past 3 decades, describing and exploring recovery and recovery-oriented practices. These studies were conducted in the community mental health and substance abuse practice. In order to further explore and build on this research on recovery, we chose to do a metasynthesis. The wish to explore in order to develop knowledge is based in our understanding of recovery as subjective, collaborative, and contextual. This involves moving from a focus on explaining to a focus on understanding. So, rather than aiming to define what recovery is, our aim with this metasynthesis is to explore how recovery can be understood in terms of personal and social contexts. The overall aim of the metasynthesis is to describe and explore the characteristics and processes of recovery. So how did we work? A core research group of 5 researchers affiliated with the Center for Mental Health and Substance Abuse collected, reviewed, and analyzed altogether 95 empirical papers, which were all based in qualitative studies at our center. We used a stepwise method for analysis, which involves synthesizing and developing meta-teams across the teams from the included papers. This analysis resulted in 3 broad topic areas and also in 3 papers. These papers are based on recovery as person context experiences, which is part 1. Part 2 is recovery as processual, and part 3 is recovery-oriented services and practices. In today's presentation, we will focus on part 1 and part 2 of this metasynthesis. And my part of the presentation is based on the paper Dynamics of Recovery, which you can see a picture of here, and it explores the experiences of recovery as person-context dynamics. And now I will move on to the findings of this part of the study. The study explores recovery as dynamics through 5 meta-themes. These are recovery as being normal, recovery as respecting and accepting oneself, recovery as being in control, recovery as intentional, and recovery as material and social. And I will now further describe each of these themes. Recovery as being normal is related to being able to carry out ordinary everyday activities, belonging in social settings as an ordinary person and participating in social life with its possibilities and obligations. The terms normality and being normal are oriented towards how recovery unfolds within the context of normal activities and environments. Taking part in ordinary daily life activities may provide structure and regularity in life and enable connections with ordinary settings and other people. Such ordinary social settings are considered to be recovery nurturing, through providing people with the possibility of doing normal activities in the same settings as others, having normal conversations, and being able to step out of the so-called patient role. Experiences of being normal depend on access to ordinary environments and activities, just like other people. Thus, participation in activities in the context of mental health services do not hold the same potential. Recovery as respecting and accepting oneself encompasses personal and relational dynamics related to the past, present, and future. This refers to multidimensional aspects of being oneself from the perspective of the self, as well as in terms of validation by others. An important aspect of recovery is to emerge as a person in terms of coming to accept oneself as one is. This involves working towards becoming who one wants to be in the future, and also to work with retrieving what may seem lost due to mental health issues. Respecting and accepting oneself is also about moving beyond the patient role and to gain self-acceptance. Support from family and others can be important in this regard. For others, spiritual support or being in nature can also fulfill this need for support. Recovery as being in control refers to taking the lead in mastering one's life, to finding ways of caring for oneself and getting to know one's possibilities, resources, and signs of ups and downs. Taking the lead in mastering one's life involves hard and continuous work. In this regard, participation in everyday life activities provide an important arena for life mastery, through the possibility of trying out and gaining new experiences and skills. However, it is also important to balance the acquiring of skills and experiences with taking care of oneself and knowing where one's limits are. In order to take care of oneself and to balance this with life mastery, becoming familiar with one's signs of ups and downs is crucial. Recovery as intentional involves the various dynamics and actions that people intentionally engage in to get better. An important part of this is working with self-acceptance and defining who one is on the one hand, in a dynamic relationship with being open to change on the other hand. Thus, embarking on a recovery journey rests upon a determination to accept and change various issues in life in order to live the best life one can. This can involve holding on to dreams and goals while also being open for new environments and new relations. Part of the dynamics between acceptance and holding on and being open for change is related to getting insight into conditions and relations that can support or hinder recovery. The final theme, recovery as material and social, refers to how recovery is understood as dynamic processes between the person and relational and material contexts. In addition to one's own efforts, having access to social life and engaging in activities with others is crucial to recovery. A positive social life enables fun and joy and can provide a valuable break from the hard work of recovery. It also involves being part of society with possibilities for both contributing and receiving. To be able to contribute to society is a crucial part of recovery, as it enables being a valuable citizen and not just a mental health patient. Access to necessary material conditions, such as satisfactory housing and enough money to live on, is of great importance to recovery. To have a sufficient income is connected to a person's possibilities to participate in activities and in social life. Having an income is also important in feeling valued as a person. Finally, having a home is paramount to recovery. A home is something more than just shelter. It can serve as a safe place for developing coping strategies, enjoying hobbies, and being with others. It can also be a place for rest and for retreat. So finally, this part 1 metasynthesis shows how recovery is not a stable concept that can be understood outside of its context. On the contrary, it shows how deeply personal experiences are entangled with contextual dimensions such as relationships and networks, social settings, attitudes and values in society, and access to material resources. The interrelatedness of the personal and contextual dimensions can be perceived as dynamics, in terms of being subject to continuous change and of mutual interaction. We suggest an understanding of recovery as an ongoing interplay between the person and others, and between the person and material resources. In line with an understanding of recovery as person-context dynamics, the findings suggest the need to work not only with the person, but also with families, networks, social systems, and local communities. Understanding recovery as person-context dynamics supports the understandings that recovery is not a stable and context-independent concept that can be implemented in services. It also supports an understanding of recovery as processual. This is where I give the word to my colleague, Mona Sommer.
Thank you for the opportunity to share some of the aspects of current understandings about recovery and recovery-oriented services. My name is Mona Sommer, and this final presentation in our symposium will cover part 2 of the metasynthesis addressing the same overall aim as presented by Trude Klevan in the previous presentation, to describe and explore the characteristics and process of recovery. Researchers have increasingly explored recovery processes from the perspective of persons with mental health problems and substance abuse problems, and stands out as something else than understanding recovery as an outcome. To develop services and communities more sensitive to people's lives and contexts, we need a deeper understanding of people's recovery processes. This presentation, with references to the article you can see here, focuses on recovery as a process, unfolding in the lived experiences of everyday life. The purpose of this metasynthesis was to try to get a deeper understanding of the complexity of recovery processes. The method applied in this study was congruent with the metasynthesis of dynamics of recovery as presented by Trude Klevan, and I will not repeat methodological details in this presentation. The findings of the study suggest that recovery as processual can be understood as having 3 meanings: recovery processes as stepwise, cyclical and continuous, recovery as everyday experiences, and recovery as relational. In the following, these meanings are described more in detail. Recovery as stepwise, cyclical and continuous involves stepping forward and stepping backward, moving between past, present and future. It is not a linear movement forward. Mental health problems intrude into everyday life, creating uncertainty and confusion and putting normal forward movement on hold. Finding out how to deal with these challenges and giving meanings to them is critical for the recovery process. Our work as service practitioners is to provide a sense of safety, as for individuals when they need to step back, and encourage hope for possibilities when they are able to step forward. Further, understanding recovery as stepwise, cyclical and continuous involves an integrated view of all aspects of life, which is considerably more than symptom management. This means recovery is about becoming an ordinary member of society, fulfilling all the expected obligations and thus having a good quality of life. For the person in recovery, An integrated understanding of recovery also includes a focus on developing a new identity, having a social life, belonging to a local community, and having hopes and dreams for the present and the future. Being stigmatized and marginalized by others in the mainstream world limits the pursuit of a normal life. Expanding of a framework of what is viewed as a valid or legitimate life could support individuals in their recovery process, helping them to move towards new identities and a sense of belonging in their local communities and in mainstream society. Recovery as everyday experiences refers to processes taking place in the context of everyday life. It includes how people integrate personal resources as well as material resources and social issues into their lives. From this perspective, recovery processes are understood as interwoven with a person's everyday life. They do not take place outside life in general. This understanding encompasses the person's struggle to achieve or remain in a normal, ordinary life, living a life in society like everyone else, with ups and downs, pleasures and sorrows. Normality has very specific meanings, such as spending time in ordinary environments with ordinary people and accomplishing the taken-for-granted activities of daily life, which can be difficult to do due to mental illness. Having a safe and comfortable home and adequate financial resources for participation in ordinary activities is critical to achieving and maintain an ordinary life. Accessing resources which include personal, material, contextual and environmental factors provide opportunities for recovery. Access to social and material resources, possibilities and enjoyment are therefore critical for personal and social recovery processes. Focusing on strengthening access to resources as a counterbalance to focusing on problems and limitations enable people to participate and engage in social and cultural activities and realize their hopes and dreams. Social relationships play a central role in recovery processes, and these include relationships with both professionals and ordinary people. Recovery as relational process addresses the importance of developing and maintaining supportive relationships because recovery takes place in relation to other people in one's environment. Supportive relationships beneficial to the recovery process includes friends, family members, professional helpers and peers. And to people recovering, being viewed as an equal, being understood and accepted, being cared for and receiving kindness are crucial. These qualities of the relationships are what matters, not the formal education or training of the helper. Relating to the recovering person as an individual person and not as an object, collaborating in mutual relationships, each recognizing the humanity of the others, matters. One's environment is the bedrock of resources that are critical, meaningful and helpful for one's living. Recovery as the process of living, thus, has to draw on the necessary and supportive resources from one's environment. Supportive environments can be peer support groups, family support, support from professionals, medication, and knowledge of one's illness and recovery process, and re-engagement in social activities. Support from others, both inside and outside mental health services, can facilitate hope for a good and meaningful life despite mental health problems. Being seen and acknowledged in social relationships create hope and helps people verbalize options and solutions in difficult life situations. Hope, nourished by supportive and reliable relationships, establishes a capacity for change in the person's recovery processes. The findings of this meta-synthesis reflect how life in general unfolds in terms of human relationships, coping, and ordinary everyday living. Based on the findings, we suggest recovery as processual experiences can result in a deeper understanding if we think of these processes more broadly and more generically. We propose 3 intertwined processes fundamental to recovery: being, doing, and accessing. Being meaning the ways the person in recovery establishes or re-establishes identity in the ever-changing and fluctuating course of life. Doing meaning how the person participates in and maneuvers in everyday life and tries to find meaning and fulfillment. And accessing meaning how the person seeks out resources and relationships in order to find pleasure and deal with the demands of life. The three areas of recovery processes, being, doing, and accessing, enhance our understanding of the interrelationship of personal efficacy and social capability, emphasizing that recovery processes are integrated into ordinary life. Perhaps most importantly, we conclude recovery practice must be understood, designed, and offered within the context of everyday life if they are to be experienced as relevant and supportive. So, for the closure of this symposium, I will give the stage, or the screen, back to Marit Borg and invite her to point out some important messages for us all to take home.
So, hello again. Some take-home messages, or so what? Or what can we learn from this research work we've been doing? One issue I think we can learn is that recovery goes on in people's everyday life, and it's both personal and social. A key learning is that recovery does not happen in professionals' offices or sites alone, or maybe not at all. A second message is that recovery needs to be built on the person's hopes and plans for his future life and for a meaningful life, and not on standardized service plans or the idea of recovery as a linear process. And as professionals or people in the audience who work as professionals, we think it's important to consider how I, as a professional, can support this plan. And maybe we need to focus on reorienting our mindsets of what we think is best for the person we have in front of us. And we also might need to spend time on fighting barriers in our organization and also in local and central and national policies. A third learning and take-home message we think is that recovery is a lot about supportive and collaborations and supportive relationships with people in services as well as in the community, and not about receiving services. And finding a meaningful life means access to resources and human rights just like everybody else. We think that a very key learning in these studies is about the value of helpful and hopeful human relationships. So before we open up for comments and questions, we have included our email addresses if you want to contact us for some issues. So thank you for your attention, and then we are ready to respond to some comments and questions. Thank you.
السلام عليكم ومساء الخير على الجميع. يتشرف مؤتمر أبو ظبي الدولي للصحة النفسية في الجلسة الخامسة من اليوم الأول أن يقدم مشاركة كل من البروفيسور طالب حنان والبروفيسور بوعافية خالد والدكتورة أمينة بن حماد والدكتور كريم عبد العزيز. سنبدأ مع الدكتورة طالب حنان. الدكتورة طالب حنان حاصلة على درجة الدكتوراه والتأهيل الجامعي، وهي أستاذ محاضر بجامعة قاصدي مرباح في الجزائر. لديها عدة مقالات في مجلات وطنية محكمة في المجالات المختلفة لعلم النفس العيادي، وهي منشورة، ولديها كذلك كتب منشورة مع آخرون حول موضوع الضغط النفسي واستراتيجيات المواجهة، بحوث ودراسات، وكتاب حول نظرة إيجابية للصدمة النفسية. الدكتور طالب لديها عدة مشاركات في مؤتمرات وطنية ودولية، مثل مشاركتها في المؤتمر الأورو متوسطي حول الجلد في علم الأحياء، ومشاركتها في المؤتمر الدولي 57 للجمعية الفرنسية لعلم النفس، ومشاركتها في المؤتمر الدولي المتعدد التخصصات، وعدة مشاركات في مؤتمر أبو ظبي الدولي للصحة النفسية للعام 2018 و2020.
بسم الله الرحمن الرحيم. السلام عليكم. أولاً أريد أن أتقدم بأسمى عبارات الشكر والامتنان إلى المسؤولين على هذا المؤتمر لإتاحتهم هذه الفرصة لتقديم هذا الموضوع الذي أعتقده مهم جداً، وهو موضوع إجهاد الشفقة وعلاقته بالجلد لدى الممرضين العاملين مع مرضى كوفيد-19، إذ نهدف من خلال هذا الموضوع إلى التعرف على مدى معاناة الممرضين العاملين في مصلحة كوفيد-19 من إجهاد الشفقة حسب سلم نوعية الحياة المهنية بروكول 5. كذلك التعرف على طبيعة العلاقة بين مستوى إجهاد الشفقة ودرجة الجلد لدى الممرضين العاملين في مصلحة كوفيد-19. كذلك التعرف على تأثير كل من السن والجنس على درجة الجلد من جهة، وعلى مستوى إجهاد الشفقة لدى الممرضين العاملين في مصلحة كوفيد-19. إذ اجتاح فيروس كورونا المستجد كوفيد-19 الذي ظهر في نهاية سنة 2019 بمدينة يوهان الصينية جميع دول العالم في وقت قياسي، إذ يتميز بسرعة العدوى والانتشار، حيث أشارت آخر الإحصائيات لمنظمة الصحة العالمية لغاية 14 من شهر نوفمبر عام 2021 على الساعة 6:25 بتوقيت غرينتش أنه أودى بحياة 5,119,354 شخص، وعدد حالات المصابين بالفيروس منذ بدايته مقدر ب 253,924,770 مصاب. أما على مستوى بلد الجزائر فقدرت حالات الوفاة ب5,977 وعدد المصابين ب207,873. هذا ما أدخل العالم في أزمات متعددة ومختلفة، وأبرزها انهيار النظم الصحية لأغلب دول العالم خاصة الفقيرة منها، وهذا ما زاد من تعقيد الوضع النفسي خاصة لمن هم في الصف الأمامي لمواجهة هذا الفيروس، وأخص بالذكر الممرضون موضوع دراستنا، إذ أنهم يعيشون ظروفا استثنائية وغير متوقعة ويواجهون خطر الموت يوميا، مما انعكس سلبا على صحتهم النفسية والجسدية. وظهرت لديهم أعراض إجهاد الشفقة بسبب احتكاكهم المستمر مع هؤلاء المرضى واستثمارهم المفرط لمعاناتهم والإشفاق على حالهم والخوف من العدوى، إذ اختلطت عليهم الأهداف والأولويات. وإذا اعتبرنا أن إجهاد الشفقة هو مجموع الانفعالات والسلوكات الطبيعية الناتجة عن التعرف على حادث صدمي تعرض له الغير عند المساعدة أو الرغبة في مساعدة شخص يعاني أو مصدوم. فإن هذا النوع من الإجهاد لا يصيب كل الممرضين، خاصة إذا استثنينا منهم الجليدين بمختلف المستويات، إذ يعتبر الجلد القدرة على النجاح والتطور إيجابياً بطريقة مقبولة اجتماعياً بالرغم من تعرض الممرض لحالة من الضغط أو الشدة التي يفترض أن تحمل في طياتها خطورة شديدة ومآلا سلبيا. وقد أشار بوريس سيرلنيك في كتابه إيفغ بارادي بونور إيرويك: المقاومة توحي بالسر حتى لا نموت ولا نجر من نحبهم إلى الموت. تظهر معاناة مقدم الرعاية وتحليه بالجلد من خلال مقاومة المصاعب من أجل المحافظة على بقائه وبقاء من يحب. ويبدو أنه من أهم ما يمكن تناوله بحثيا هو تداخل هذه العوامل وتأثيرها على الممرضين من خلال دراستها في علاقتها مع بعضها البعض، إضافة للمتغيرات الديمغرافية كالسن والجنس. فجاءت التساؤلات كما يلي: ما مدى معاناة الممرضين العاملين مع مرضى كوفيد-19 من إجهاد الشفقة؟ هل توجد علاقة دالة إحصائياً بين درجة الجلد ودرجة إجهاد الشفقة لدى الممرضين العاملين مع مرضى كوفيد-19؟ هل هناك فروق ذات دلالة إحصائية في درجة الجلد لديهم تعزل الجنس؟ هل يتأثر مستوى إجهاد الشفقة لديهم باختلاف الجنس والسن؟ نتطرق الآن إلى أهمية هذه الدراسة، إذ تنبع أهميتها من تناولها موضوعا حديثا في علم النفس بتطرقها للجلد وانتمائها لفرع جديد وهو علم النفس الإيجابي. كما أن الدراسات التي تطرقت لإجهاد الشفقة عند الممرضين العاملين في مصلحة كوفيد-19 من جهة وللجلد من جهة أخرى قليلة، إن لم نقل منعدمة، على الصعيد المحلي والعربي. ومن هنا تأتي حداثة هذا الموضوع وأصالته، كونه موضوعا جديدا سيكون بمثابة إضافة إلى التراث السيكولوجي في مجال الصدمة والإجهاد النفسيين في خضم هذه الأزمة الصحية التي يعيشها العالم. تتمثل الحدود المكانية لهذه الدراسة في بعض المستشفيات العمومية بمختلف ربوع الجزائر. أما حدودها الزمنية فقد امتدت دراستنا في الفترة ما بين 15 نوفمبر 2020 إلى غاية 12 أكتوبر 2021. تضمنت عينة دراستنا الممرضين العاملين مع مرضى كوفيد-19 في المستشفيات العمومية، وقدر عددهم ب 452 ممرضا، وقد اختيروا بطريقة عشوائية. أدوات الدراسة: استخدمنا في دراستنا هذه أداتين، وهما سلم نوعية الحياة المهنية بروكول 5 لبيث هادنال ستام 2009، والذي يتكون من 3 سلالم فرعية هي رضا الشفقة والاحتراق النفسي وإجهاد الشفقة، إذ قامت الباحثة الدكتورة طالب حنان بترجمته وتكييفه على البيئة العربية. وثانياً استخدمنا سلم الجلد لكونور أند دافيدسون، وقد تم إجراء ترجمته من طرف فريق بحث بمخبر علم النفس الإكلينيكي بجامعة سطيف 2 الجزائر. النتائج: نأتي الآن إلى عرض نتائج الدراسة. عرض نتائج الفرضية الأولى، والتي نصت على: يعاني الممرضون العاملون مع مرضى كوفيد-19 من إجهاد الشفقة بنسبة عالية حسب سلم نوعية الحياة المهنية. ولقد تم التحقق من صحة هذه الفرضية بحساب مجموع الاستجابات والمتوسطات والانحرافات المعيارية والوزن النسبي لكل فقرة، كما هو مبين في الجدول التالي. إذ نلاحظ من الجدول أن المستوى العام لإجهاد الشفقة كان 86.01، ويعود تفسير ذلك إلى عدة عوامل منها الداخلية والخارجية، فظهور فيروس كوفيد-19 الخطير وسريع الانتشار أحدث هلعا واضطرابا عالميا على جميع المستويات، كما أن الممرض يجد نفسه أمام مريض يعاني جسديا ونفسيا في ظل غياب العلاج وندرة الأدوية المخففة وندرة عبوات الأكسجين، مما يجعله فريسة لإجهاد الشفقة. عرض وتحليل وتفسير نتائج الفرضية الثانية، والتي تنص على توجد علاقة ارتباطية ذات دلالة إحصائية بين إجهاد الشفقة والجلد لدى عينة الدراسة، حيث تم حساب العلاقة الارتباطية بيرسون كما هو موضح في الجدول التالي. إذ نلاحظ من الجدول أن معامل ارتباط بيرسون قدر بالناقص 0.66 وهو دال عند 0.00، وبالتالي فإنه توجد علاقة بين إجهاد الشفقة والجلد، ولكنها عكسية، أي أنه كلما ارتفع الجلد انخفض إجهاد الشفقة، وكلما انخفض الجلد ارتفع إجهاد الشفقة. عرض وتحليل ومناقشة وتفسير نتائج الفرضية الثالثة، والتي تنص على وجود فروق دالة إحصائيا في مستوى إجهاد الشفقة لدى الممرضين العاملين مع مرضى كوفيد-19 تعزى إلى السن، حيث نلاحظ في الجدول أن قيمة فا هي 0.56 وهي غير دالة، ومنه فإننا ننفي وجود فروق في مستوى إجهاد الشفقة يعزى إلى السن، ومنه فالفرضية لم تتحقق. ونلاحظ من هذا الشكل أن مستويات إجهاد الشفقة حسب الفئات العمرية في هذه الدراسة لم تلعب دورا هاما أمام وباء كوفيد-19 سريع الانتشار والخطير والغامض، وهذا ما ألغى الفروق في السن في إجهاد الشفقة لدى أفراد العينة. عرض وتحليل ومناقشة وتفسير نتائج الفرضية الرابعة، أي توجد فروق دالة إحصائيا في مستوى الجلد بين الجنسين، وهو ما يوضحه الجدول التالي. نلاحظ أن قيمة المحسوبة هي 0.39 وهي غير دالة، ومنه نستنتج أنه لا توجد فروق في الجلد بين الجنسين في عينة الدراسة، وهذا راجع إلى حالة القلق والهلع المستمرة نتيجة استمرار الوضع وتكرار مشاهد الإصابات والوفيات، وكذلك وعي الممرضين بمدى انتشار العدوى والحالات المهددة الأكثر بالمضاعفات مثل المرضى المزمنين والمسنين والبادنين، إلا أنها لا تفرق بين الجنسين. عرض وتحليل ومناقشة وتفسير نتائج الفرضية الخامسة، وتنص على توجد فروق دالة إحصائيا في مستوى إجهاد الشفقة تعزى إلى الجنس، وكما هو موضح في هذا الجدول. نلاحظ أن تاء المحسوبة قدرت ب0.25 وهي غير دالة، ومنه نستنتج أنه لا توجد فروق في إجهاد الشفقة تعزى إلى الجنسين. وكخاتمة، انطلقت دراستنا الحالية من فرضية معاناة الممرضين العاملين مع مرضى كوفيد-19 من مستوى مرتفع من إجهاد الشفقة والتي تحققت، وتليها فرضية وجود علاقة ارتباطية بين إجهاد الشفقة والجلد لدى الممرضين العاملين مع مرضى كوفيد-19، حيث أثبتت وجود علاقة عكسية في مستوى إجهاد الشفقة والجلد، في حين أثبتت الفرضية أن إجهاد الشفقة لم يتأثر بعاملي السن والجنس، ويعزى ذلك إلى أن حالة الوباء المستجد لم يكن له سوابق من حيث التعامل معه كحالة قابلة للعلاج السريع والتكفل بالحالات بصورة صحيحة. أما بالنسبة لفرضية الفروق في الجلد عند الجنسين فلم تكن دالة، ويمكن إرجاع ذلك إلى حالة الصدمة التي تلقاها فريق العمل من مختلف الجنسين. نعتقد أن هذه النتائج قد سمحت لنا بكشف العلاقة بين إجهاد الشفقة والجلد والوصول إلى استنتاجات يمكن استغلالها وتوظيفها في الجانب الوقائي النفسي، وكذلك اعتمادها في البرامج العلاجية. في الأخير نخلص إلى مجموعة من التوصيات والتي نعرضها فيما يلي. أولاً، استحداث تخصص فرعي جديد في مجال العلوم النفسية وهو علم النفس الوبائي، تحضير الممرضين وطلبة التمريض للتعامل مع حالات الأوبئة والطوارئ، وضع استراتيجيات وقائية للحد من الإجهاد النفسي والجسدي عن طريق تطوير قدرات الجلد لدى الممرضين، خضوع الممرضين للتنقل بين مختلف المصالح بشكل دوري. وفي الأخير نشكركم على حسن الإصغاء.
شكرا بروفيسور طالب حنان. ننتقل للمتحدث الثاني، البروفيسور بوعافية خالد، أستاذ محاضر بجامعة قاصدي مرباح ورقلة الجزائر. البروفيسور حاصل على درجة دكتوراه والتأهيل الجامعي في علم النفس العصبي، ولديه العديد من المقالات، نذكر منها مقالة مناقشة وتطوير نموذج أودولفس 2000 بإضافة نظرية العقل لشرح الأسس القشرية لإدراك انفعالات الملامح الوجهية، وورقة حول أنماط إدراك الانفعالات الوجهية وسيرورتها العصبية لدى الأطفال ذوي تناظر أسبرجر، والعلوم العصبية المعرفية والتربية روابط مشتركة واهتمامات مستجدة. كما ساهم الدكتور بوعافية في ترجمة وتقنين استبيان تشخيص التوحد من المستوى العالي لبارون كوهن. شارك في العديد من المؤتمرات مثل مؤتمر الأورو متوسطي حول الجلد في علم الإحياء، والمؤتمر الدولي الثالث للعلوم العصبية حول واقع العلوم العصبية، والمؤتمر الدولي 57 للجمعية الفرنسية لعلم النفس، والمؤتمر الدولي المتعدد التخصصات حول نوعية الحياة في المدرسة. كما شارك في مؤتمر أبو ظبي الدولي للصحة النفسية للعامين 2018 و2020.
بسم الله الرحمن الرحيم. مرحبا بكم في هذا اللقاء الجديد لهذا المؤتمر العلمي الراقي جدا، والذي يجب أن نشكر جميع القائمين عليه من دكاترة وعلماء باحثين، والذين قدموا لنا هذه الفرصة لنكون بينهم في هذه الجلسة العلمية التي نتمنى أن تبقى دائما مستمرة ومتجددة، وأن نلتقي إن شاء الله في المستقبل لقاءات فعلية. مداخلتنا ستكون حول تقييم الأعراض النفسية الجسدية لمتلازمة الحجر الصحي من وجهة نظر الأخصائيين النفسانيين والأطباء. في التقديم يجب أن نشير إلى أن وباء كوفيد-19 أضفى الكثير من التغييرات في مفاهيم وشروح للعديد من الاضطرابات النفسية، الأمر الذي دفع قدما بالبحث السيكولوجي نحو التطور والتكيف مع هذا المعطى الجديد الغامض إلى حد بعيد، إذ تعتبر هذه المتلازمة شديدة الارتباط بظروف هذا الوباء وإجراءات مكافحته والحد منه، ما يجعل هذا المفهوم في أمس الحاجة للمراجعة والتحيين. تعتمد الدراسة الحالية أو ستعمد الدراسة الحالية إلى صبر آراء عدد من المختصين من أطباء ونفسانيين عايشوا الوباء من ذوي الخبرة في التعامل مع أفراد أصيبوا بالكوفيد، خاصة وأن هذا الاضطراب في حد ذاته لم يستقر بعد على مستوى التشخيص والتصنيف، ونقصد بهذا متلازمة الحجر الصحي. بناء على ما صرح به الدكتور فايل رايت، وهو عالم نفس ومدير البحوث السريرية والجودة في جمعية علم النفس الأمريكية، بأن حمى المقصورة أو متلازمة الكوخ أو التي هي موضوع دراستنا وهي متلازمة الحجر الصحي ليست مثل بقية الاضطرابات النفسية، لذلك يقول بأنه لن يقول أن هناك أي نوع من التعريف الرسمي لها، قد لا تكون حالة حقيقية لكن المشاعر المرتبطة بها حقيقية للغاية، ولذلك نحن في حاجة كبيرة جدا لدراسة هذه المتلازمة وفهمها جيدا، وجمع أكبر عدد ممكن من الأعراض التي يمكن أن نتفق عليها حول هذه المتلازمة. إذن بالرغم من عدم اعتباره اضطرابا نفسيا مصنفا وواضحا، إلا أن متلازمة الحلزون أو متلازمة الكوخ أو ما يسمى حديثا بمتلازمة الحجر الصحي يعد أحد أهم أشكال المعاناة النفسية التي طفحت إلى السطح بعد انتشار وباء كورونا، جراء غلق المجال وتضييق الحريات الاجتماعية لتطبيق إجراءات الحجر المنزلي وتقييد مجال الحركة والتجمعات العمومية والتواصل المباشر والقريب بين الأفراد وحتى من نفس العائلة. كل هذه القيود أصبحت تشكل عبئا ثقيلا على الأفراد بمختلف أعمارهم وطبقاتهم، علاوة على المخاوف المتزايدة والمبررة من الإصابة الفيروسية. هذه الدراسة أكيد لها أسس نظرية تنطلق من اختلاف استجابات الأفراد لأسباب متلازمة وتطويرهم لأعراضها، وهذا يعود طبعا يعني سيكولوجيا دائما يعود ذلك إلى اختلاف استعداداتهم وسوابقهم المرضية النفسية، إذ يشير الأخصائيون النفسانيون إلى أن أعراض متلازمة الحلزون أعمق بكثير من الشعور بالملل. هي ليست فقط الشعور بالملل من جراء الغلق، ولكنها ترجع في الأصل إلى الشعور القوي بالعزلة. لذلك فإن لها العديد من الآثار العاطفية والجسدية والسلوكية، وهو ما ستقوم به دراستنا حاليا، والتي يمكن لهذه الآثار طبعا أن تؤدي بشكل واضح ومباشر إلى تراجع في جودة حياة الشخص، خاصة فيما يتعلق بالعلاقات بسبب شعوره بعدم قدرته على التواصل المباشر والعادي مع الأقارب والأصدقاء والناس الذين كان يتواصل معهم سابقا. طبعا هناك مجموعة من الإجراءات المنهجية التي تم اتخاذها في هذه الدراسة، إذ قمنا بتقديم أداة في شكل استبانة أسست علميا ومنهجيا بالاعتماد على صبر آراء عدد من الأخصائيين النفسانيين والأطباء لتقديم ملاحظاتهم المتخصصة في شكل استبيان يتضمن عددا من الأعراض. كمنطلق بحثي سيكولوجي كلينيكي، الهدف الأساسي منه هو إعادة النظر في أعراض هذه المتلازمة، خاصة وأن هذا المصطلح كما قلنا لم يستقر بعد في التصانيف التشخيصية النفسية. إذن إعادة النظر في أعراض هذه المتلازمة وفقا للمعطيات الجديدة المرافقة للوباء. بلغ عدد هؤلاء المختصين 156 مختصا، منهم 56 مختصا نفسيا و100 طبيب من مختلف الاختصاصات، إذ تم التركيز فقط على شرط أن يكونوا قد عملوا في مصالح العناية بمرضى الكوفيد في المستشفيات أو في المنازل أو مع أفراد أصيبوا بالعدوى وشفوا من المرض. إذن كل هذه الدراسة ستكون بهدف تقييم وحصر الأعراض النفسية والانفعالية، أي جمع أكبر عدد ممكن من الأعراض التي ستحظى بالإجماع، وحتى بعض العلامات الجسدية الناجمة عن متلازمة الحجر الصحي أو ما يسمى بمتلازمة الكوخ. وقد تم بالفعل التوصل إلى أهم النقاط التي يمكن أن تعتبر مؤشرات منبئة بهذه الإصابة في سبيل الوقاية منها. كما تم الاتفاق أيضا على أبرز العلامات التي تضاف كأعراض للمتلازمة في حال تم تصنيفها مستقبلا ضمن الاضطرابات النفسية المعتمدة ذات الأعراض الواضحة. إذن بعد تقديم الاستبانة تحصلنا على مجموعة من الأعراض، إذن أعراض جسدية، أعراض انفعالية مزاجية، وأعراض أخرى معرفية. إذن سنبدأ بالأعراض الجسدية. إذن صدق المحكمون على يعني عدد نسبة الأعراض التي حصلت أو نسبة الموافقة على مجموعة من الأعراض حصلت على أقل من 40% من طرف المحكمين المختصين، التي هي الصداع، عسر الهضم، شحوب، اضطرابات جنسية، تساقط الشعر، اضطرابات في الطمث، تشنجات عضلية. هناك أعراض أخرى وافق عليها من 40 إلى 70% من المحكمين، والتي على سبيل المثال لا الحصر سنذكر بعضها فقط نظرا لاحترام الوقت: الشعور بالغثيان، التعرق الزائد، آلام غير مبررة، ارتجاف وارتعاش، والدوار. وهناك أعراض أخرى أيضا والتي حصلت على أكثر من 70% من آراء المحكمين أو من موافقة المحكمين، وهي عدم انتظام نبضات القلب، تغيرات في الوزن في شكل هزال أو سمنة، اضطرابات في النوم على شكل أرق، الخمول والشعور المستمر بالإعياء، آلام في الظهر وفي بعض المفاصل، التعب والوهن والضيق في التنفس والإمساك. بالنسبة إذن هذه دائرة نسبية توضح لنا نسب موافقة المحكمين من 70 إلى 40 ومن أكثر من 70 وأقل من 40. هذا فيما يتعلق بالأعراض الجسدية. بالنسبة للأعراض النفسية والتي تضمنت الأعراض الانفعالية والمزاجية، فقد وافق المحكمون أقل من 40% فقط على عرضين التي هي العدوانية والعصبية الزائدة وتعاطي الكحول. ربما يتعلق هذا بالبيئة التي تم فيها تطبيق هذه الدراسة. من 40 إلى 70% من المحكمين وافقوا على المبالغة في الحذر وأخذ الحيطة، فقدان الثقة في الذات، الشره، نوبات الهلع، الخوف، القلق والتململ، سرعة الانفعال، انخفاض الحماس، تعاطي الأدوية ذات الانتحاء النفسي، الميل نحو العزلة والانطواء. أكثر من 70% من المحكمين وافقوا على قلق الموت وانتشاره خاصة لدى المسنين والمرضى المزمنين والحوامل. وافقوا أيضا على أعراض وسواسية الشكل، على توهم المرض، على تقلبات مزاجية غير مبررة. وافقوا أيضا على مشاعر اليأس، الحزن أو تمظهرات اكتئابية، فقدان الاستمتاع، فقدان الرغبة في ممارسة الهوايات اليومية، توترات في العلاقات الزوجية، الخوف من مغادرة مكان الإقامة، الحصر، هبوط في المزاج وبطء نفسه حركي. إذن هذه جملة من الأعراض التي حظيت بنسبة كبيرة من الموافقة لدى المحكمين. إذن هذه الدائرة توضح جيدا النسبة التي حصلت عليها الأعراض النفسية والتي تضمنت الانفعالية والمزاجية. بالنسبة للأعراض المعرفية، إذن وافق المحكمون فقط على عرض واحد وهو الأفكار الانتحارية. يعني أقل من 40% فقط وافقوا على اعتبار الأفكار الانتحارية واحد من الأعراض المعرفية التي يمكن أن تضاف إلى متلازمة الحجر الصحي. أما من 40 إلى 70% من المحكمين وافقوا على المبالغة في الحذر وأخذ الحيطة، الملل، التشوش الذهني خاصة لدى المسنين، الصعوبة في تقديم الأحكام أو إطلاق الأحكام نظرا لاختلاط الأمور، اختلاط الأفكار والمقدمات إلى غير ذلك، وحالة الخوف التي ربما يعيشها هؤلاء المصابون بهذه المتلازمات. كذلك وافقوا على التصورات السلبية عن الذات، إيذاء الذات، صعوبات في الكلام، عجز عن التعبير بمختلف أنواعه، واضطراب في التوجه الفضائي والزماني. وهذا أيضا خاصة لوحظ بشكل كبير جدا عند المسنين. أما ما نسبته أكثر من 70% من المحكمين فقد وافقوا على الميول نحو نمط تفكير سلبي، وهذا عرض مهم جدا خاصة ويرتبط بشكل كبير جدا بظروف انتشار وباء كوفيد-19. كذلك وافقوا على الصعوبة في التركيز أو مشكلات التركيز. لماذا؟ لأن الصعوبات في التركيز ترتبط بالشعور المستمر بالخوف من الموت، الخوف من العدوى، الخوف من الإصابة، بمشاهدة أعداد المصابين التي تتزايد يوميا. إذن يؤثر كل ذلك على التركيز. كذلك لاحظوا بأن هناك مشكلات في الأداء الذهني من نمط المبادرة والمتابعة، وهذا أيضا يرتبط وجه آخر من أوجه صعوبة التركيز ولكنها سجلت لوحدها. لماذا؟ لأن الأفراد وهم في حالة الحجر مطالبون، كثير منهم كانوا مطالبين بمواصلة أعمالهم، مواصلة نشاطاتهم، وهذا ما يتطلب منهم أداء ذهنيا يسمح لهم بالمبادرة المستمرة ومتابعة أعمالهم. كذلك وافق أكثر من 70% من المختصين على المشكلات في التفاعلات الاجتماعية، وهذا شيء سيكون واضحا جدا. كذلك وافقوا على الحمائية الزائدة التي قد تظهرها بعض الأمهات تجاه أبنائهم أو بعض أفراد الأسرة تجاه المسنين أو تجاه الذين عندهم سوابق مرضية. إذن ستكون هناك حمائية زائدة ربما مبالغ فيها أكثر مما هو مطلوب صحيا. كذلك وافقوا على انخفاض في الدافعية للإنجاز، وهذا مشكل واضح جدا يعود بشكل كبير جدا إلى حالة الحجر أو حالة الغلق التي يعيشها الأفراد في ظل هذا الوباء. كذلك لاحظوا أو وافقوا على عرض مهم جدا وهو اللا يقين. لماذا؟ لأن هذا الوباء يعتبر وباء غامضا لم تظهر معالمه بعد، وبالتالي كل شيء فيه خاضع للشك. إذن عرض آخر وهو إصدار الأحكام المبنية على الغموض، الخوف من المستقبل وتوقع الأسوأ، والمبالغة في تعاطي أدوية الإنفلونزا. كذلك هناك أعراض أخرى وهي أعراض تجنبية، خوف من التعامل مع الغرباء، التركيز المبالغ على الأعراض الجسدية، صعوبات في إعادة التكيف مع العالم الخارجي، الاستغراق المعرفي في المواضيع ذات الصلة بالوباء، التفكير اللا منطقي ولا عقلاني. وهذه الدائرة كذلك توضح نسب الموافقة التي حظيت بها الأعراض المعرفية. إذن كخلاصة لكل ما قدمناه، تعتبر العلامات التي وافق عليها ما نسبته أقل من 40% من المحكمين يمكن أن نعتبرها مؤشرات للاضطراب، أي أن الشخص إذا ظهرت عنده تلك العلامات في البداية يمكن أن نعتبرها مؤشرات الاضطراب. أما العلامات التي وافق عليها ما نسبته من 40 إلى 70% من المحكمين يمكن أن تعتبر أعراض منبئة بالاضطراب. أما العلامات التي وافق عليها ما نسبته أكثر من 70% من المحكمين يمكن أن نعتبرها فعليا أعراض حقيقية لهذا الاضطراب أو لهذه المتلازمة. إذن هذا ما يمكن أن نقدمه في عجالة حول هذه الدراسة. إذا كانت لنا فرصة سنقدم تفاصيل أكثر. نشكركم على المتابعة وشكرا لكم.
شكرا بروفيسور بوعافية. ننتقل إلى الدكتورة أمينة بن حماد. الدكتورة أمينة حاصلة على شهادة الدكتوراه في علم الاجتماع التطبيقي من جامعة الشارقة في تخصص سياسات التنمية، التخصص الدقيق سياسات الصحة النفسية. تحمل شهادة خبير في السياسات العامة المتقدمة من كلية محمد بن راشد الحكومية، ولديها أكثر من 10 سنوات خبرة في المجال النفسي والاجتماعي. عملت على صياغة وتقييم وتحليل السياسات، وقدمت العديد من برامج التوعية والتدريبات التخصصية في مؤسسات أكاديمية ومجتمعية متعلقة بموضوع الصحة النفسية، كما قدمت استشارات نفسية وفردية وجمعية في تأهيل الحالات الأكثر عرضة لضحايا العنف والمنزلي وسوء معاملة الأطفال وضحايا الإتجار بالبشر، ولديها أوراق عمل وأبحاث منشورة. الكلفة الاجتماعية للمرض النفسي نحو سياسة للصحة النفسية في مجتمع الإمارات. في البداية أشكر البروفيسور نايف البنوي على الإشراف، وكلية الدراسات العليا بجامعة الشارقة، ووزارة الصحة ووقاية المجتمع على دعمهم وتعاونهم في إجراء هذه الدراسة. سنتعرض إلى مشكلة الدراسة وأهميتها، والدراسات ذات الصلة وأهداف الدراسة والمنهجية، ثم نخلص إلى أهم النتائج والتوصيات. من المبادئ الرئيسية للحصول على دعم صناع السياسات والمخططين مبدأ بناء البرهان التقني، وهو أولاً أن نظهر ضخامة الاضطرابات النفسية، ثم نسلط الضوء على تكاليف الاضطرابات النفسية ونستعرف التدخلات النفسية الفعالة، ومن ثم نستعرف الجدوى الاقتصادية. فجاءت هذه الدراسة لتسليط الضوء على تكاليف الاضطرابات النفسية. منذ 30 عاماً تثبت الدراسات، طبعاً هذا تحليل نفسي يبين أن منذ 30 عاماً من 1990 وحتى 2019 لا زالت الاضطرابات النفسية في المرتبة الثانية من حيث أنها تشكل العبء المرضي العالمي. مشكلة الدراسة، طبعاً بما أن العبء المرضي العالمي في تزايد، فإن هذا التزايد المتسارع سيزيد من الآثار الجسيمة التي تلحق بالمريض وأسرته ومجتمعه، وبالتالي سيعاني المرضى النفسيون من كلف اجتماعية متعددة وباهظة تؤثر على سير حياتهم وقدرتهم على التعايش، وبالتالي كذلك ستؤثر هذه الكلف على الصحة النفسية لأسرة المريض، مما يضاعف الأثر الاجتماعي السلبي على المجتمع. فجودة الخدمات النفسية قد تشجع أو تعيق عملية التعافي المتوقعة، فتتحول إلى كلفة اجتماعية بدل أن تكون مساهماً في التعافي وتحقيق الأهداف. وكلفة الوصم قد تمنع المرضى النفسيين من الحصول على الخدمات التي شرعها لهم القانون على الرغم من توفرها. وكلفة ضعف العلاقات الاجتماعية قد تؤدي إلى خلل في منظومة العلاقات على المستوى الفردي للمريض نفسه أو أسرته. طبعا وكلفة هدر الموارد المالية قد تسبب الفقر والعوز في حال عدم وجود مصادر أخرى لدخل المريض النفسي، ونظرا لنقص البيانات والمعلومات المتعلقة بالأمراض النفسية وكلفتها الاجتماعية على مستوى العالم وعلى المستوى الإقليمي بشكل عام وفي دولة الإمارات العربية بشكل خاص، برزت حاجة ملحة إلى البحث حول هذا الموضوع. أهمية الدراسة. تأتي أهمية الدراسة، هناك أهمية نظرية وأهمية تطبيقية لهذه الدراسة. الأهمية النظرية أن هذه الدراسة تسهم في سد الفجوة البحثية، فقد عالجت موضوع جديد بالنسبة للدراسات المحلية، أكثرها كانت عن الاضطرابات النفسية والمشكلات الاجتماعية. هناك دراسة واحدة فقط تناولت سياسات الصحة النفسية من ناحية جودة الخدمات ومن وجهة نظر الممارسين، كما أن هذه الدراسة تأتي وتعتمد على المقابلة وليس البيانات المتوافرة كما كانت في الدراسات السابقة. وهذه الدراسة كذلك كتبت ونشرت باللغة العربية، فأكثر النشاطات البحثية قد لا تتعلق بشكل مباشر باحتياجات المجتمع وغالبا ما تتم باللغة الإنجليزية. أما من الناحية التطبيقية فنتائج هذه الدراسة ستساهم في فهم وتحليل أوجه القصور، مما سيساهم في صياغة السياسات الخاصة بالمرضى النفسيين وتوجيه البرامج والمبادرات بأساس منطلق من الواقع والمعلومات والبيانات الموجودة في هذا البحث، بداية لمجهودات بحثية لاحقة في مجال العمل الاجتماعي والسياسات التنموية. على المستوى العالمي هناك عدة دراسات تناولت الكلفة الاجتماعية للمرض النفسي. دراسات اهتمت بتقييم طبيعة خدمات الصحة النفسية التي تقدم للمرضى النفسيين، ودراسات اهتمت بالكلفة المباشرة وغير المباشرة للأمراض النفسية، ودراسات اهتمت بأثر ومخاطر القيمة الإحصائية للأمراض النفسية على الفرد والمجتمع. في دراسة مقارنة بين عام 2008-2018 أجريت في الولايات المتحدة الأمريكية من قبل مركز المسح الوطني حول أسباب عدم حصول المرضى على خدمات الصحة النفسية. وجدت هذه الدراسة أن الأسباب لم تتغير خلال السنوات السابقة. هذه الدراسة كانت بين 2008، مقارنة بين نتائج 2008 و2018 حول الكلفة الاجتماعية. لا زالت أول سبب يمنع المرضى النفسيين من الحصول على الخدمات العلاجية هو عدم قدرتهم على تحمل كلفة العلاج، وثانياً اعتقادهم بأنهم يستطيعون السيطرة على المرض، وثالثاً أنهم لم يعرفوا أين يذهبوا للحصول على الخدمة، ورابعاً أنهم لم يجدوا الوقت الكافي لذلك، وخامساً لأن تأمينهم الطبي لا يغطي العلاج، وسادساً خشيتهم من إلزامهم بالعلاج الدوائي، وسابعاً قلقهم من مستوى السرية، وثامناً خشيتهم من نظرة السلبية، وتاسعاً خوفهم من تأثر وظيفتهم الحالية بسبب العلاج، وعاشراً عدم رغبتهم في أن يعرف الآخرون حول موضوع علاجهم. طبعاً هناك عدة دراسات حصلت على مستوى كذلك الخليج ودراسات عالمية، لكن أكثر هذه الدراسات اتفقت أن هناك خسائر وكلف يتكبدها المرضى النفسيون ويعانون منها حتى في الدول التي تمتلك سياسات في الصحة النفسية، وهذه الخسائر قد تكون أكبر من الواقع. هذه الدراسة ستتعرف إلى أبرز الكلف الاجتماعية الناتجة عن المرض النفسي من حيث كلفة جودة الخدمات، وكلفة الوصم الاجتماعي، وكلفة العلاقات الاجتماعية، وكلفة العمل، والكلفة المالية. والتساؤل الرئيسي لهذه الدراسة هو: ما هي الكلف الاجتماعية للمرض النفسي في مجتمع الإمارات؟ والتساؤلات الفرعية ستركز على أبرز الكلف التي يتكبدها المرضى النفسيون من حيث مظاهر الكلف المتعلقة بالخدمات المقدمة، ومظاهر كلفة الوصم الاجتماعي، ومظاهر كلفة العلاقات الاجتماعية، ومظاهر كلفة العمل، ومظاهر الكلف المالية لدى المرضى النفسيين. طبعاً هذه الدراسة تعتبر من الدراسات النوعية ذات الأهداف التحليلية التي تركز على خبرات ومعتقدات الفرد بطرح أسئلة مفتوحة. اعتمدت هذه الدراسة على جمع البيانات من خلال أسلوب المقابلات الفردية المتعمقة، حيث أجريت المقابلة من قبل الباحث نفسه مع مستجيب واحد في كل مرة بشكل مباشر وبشكل غير مباشر من خلال المقابلات الهاتفية، واستغرقت كل واحدة ما يقارب من 20 إلى 40 دقيقة. بلغت العينة النهائية 38 من المرضى النفسيين. طبعا أداة الدراسة هي المقابلة، واعتمدت في تحليلها على التحليل النوعي بناء على التعبيرات التي أفاد بها المرضى النفسيون من خلال خبراتهم وتجاربهم. هذه هي الخصائص الديموغرافية للعينة. من الذكور كانوا 20 ومن الإناث 18، وتراوح العمر بين 19 إلى 68، وأكثر العينة كانت من إمارة دبي ثم الشارقة ثم عجمان. الحالة الاجتماعية تم قياسه بحيث كانوا منهم 20 من الأعزب ومتزوجين 9، ومطلقين 5، ومن الأرامل 4. مستوى التعليم تراوح، لكن أكثرهم كان في المرحلة الثانوية. 14 منهم لم يكمل تعليمهم بسبب المرض، 21 منهم يعملون، و17 من العينة لا يعملون، وتراوح العمل بين أشهر إلى 20 سنة. و18 منهم يعملون في القطاع الحكومي، و2 منهم يعملون في شبه الحكومي، و1 في الخاص. ومنعهم، هل منعك المرض من العمل؟ نعم بنسبة 21، ولم يمنعني المرض من العمل بنسبة 17. دخل الأسرة تراوح بين قليل ومتوسط وعالي، وكان أكثرهم بين المتوسط والقليل. 22 منهم تلقوا العلاج من جهة حكومية، وبعضهم حصلوا على الخدمة العلاجية في وقت من الأوقات من جهتين حكومي وخاص بنسبة 16 من عدد الكلي للعينة. وإجمالي مدة العلاج تراوحت بين سنة إلى 35 سنة. بالنسبة للعمر تظهر خصائص العينة إعداد المشاركين من الذكور مقارب لإعداد الإناث، مثل ما قلنا، وتراوحت الأعمار بين 19 سنة إلى 68. يعني أكثر مشاركة من قبل العينة تركزت في عمر الأربعينيات. أما بالنسبة للسكن فأكثرهم من مدينة دبي، ويعزى ذلك إلى قرب المدينة، وجود المستشفى في داخل مدينة دبي. وأقل مشاركة كانت من مدينة أبو ظبي، ويعزى إلى وجود مؤسسات حكومية في مدينة أبو ظبي تقدم خدمات الصحة النفسية بشكل مجاني، وأن المقابلات هذه تمت في فترة عدم استقرار الوضع الصحي بسبب جائحة كوفيد. الحالة الاجتماعية كانت أكثر العينة من غير المتزوجين، وأفاد بعضهم أثناء المقابلة عن عدم التفكير في الزواج خوفاً من عدم حصول الاستقرار الأسري بسبب مرضهم النفسي أو عدم تفهم الطرف الآخر لطبيعة المرض. وأفاد البعض بأن الطلاق حصل بسبب المرض النفسي، وصر أحد المرضى النفسيين المتزوجين بأن زوجته تطلب الطلاق باستمرار بسبب المرض النفسي. بالنسبة للتعليم أكثر العينة من الحاصلين على التعليم الثانوي، فذلك يشير إلى تأثير مواصلة التعليم بطبيعة المرض النفسي لدى العينة، وتساوى عدد الجامعيين مع الحاصلين على التعليم حتى الإعدادي، كما تساوى الحاصلين على التعليم الابتدائي مع الأميين. بالنسبة لاستمرارية التعليم أفاد البعض بأنهم اضطروا للتوقف عن التعليم عدة مرات بسبب مرضه النفسي، ثم استطاعوا المواصلة بعد الحصول على تشجيع الأسرة أو الطبيب المعالج. نأتي إلى النتائج المتعلقة بمظاهر الكلف الاجتماعية. أظهرت نتائج الدراسة أن سياسات الصحة النفسية في مجتمع الإمارات ساهمت بشكل إيجابي في التخفيف من بعض الكلف الاجتماعية، مثل كلفة جودة الخدمات المقدمة للمرضى النفسيين، والتي أكد المبحوثين رضاهم عنها بشكل عام على الرغم من وجود بعض الكلف السلبية المرتبطة بها. وساهمت كذلك في التخفيف من كلفة فقد العلاقات الأسرية، فقد أكد المبحوثين على قوة العلاقة الأسرية والدعم الأسري الذي يتلقونه بسبب مرضهم النفسي. كما ساهمت سياسات الصحة النفسية في الحد من الكلفة المالية المتعلقة بالعلاج، حيث أكد المبحوثين على عدم وجود كلفة مالية تتعلق بالحصولهم على العلاج أو الدواء في المؤسسات الصحية الحكومية. وفي المقابل عبر المرضى النفسيين عن بعض المظاهر التي تدل على وجود كلف اجتماعية من عدة نواحي أخرى، هي كلفة متعلقة بالخدمات المقدمة في جوانب محددة، وكانت مظاهرها قلة خيارات العلاج المتوفرة، وبعد السكن عن بعد المستشفى عن مكان السكن، وضآلة كمية المعلومات المكتسبة حول حالاتهم الصحية، وتأخر موعد المراجعة، وتغير الطبيب باستمرار، وضعف المتابعة اللاحقة. ثانياً، كلفة الوصم الاجتماعي تم تحليلها بحسب لينك وفيلن، حيث كانت مظاهرها وجود مشاعر الاختلاف عن المجتمع، وتكون صورة نمطية سلبية حول المرض النفسي لدى المجتمع، تمثلت في استخدام بعض الكلمات الدارجة مثل مبصاحي أو ناقص، واتضحت مظاهر الانفصال المعرفي في الاستخدام المتكرر لنحن وهم، كما اتضحت لدى العينة ردود أفعال عاطفية، حيث أفادوا بأنهم يشعرون بالعار لاختلاف طريقة تحدث المجتمع معهم، واتضحت مظاهر فقدان المكانة في إحساسهم بقلة الاهتمام وضعف القبول الاجتماعي. بالنسبة لكلفة العلاقات الاجتماعية، كانت مظاهرها فقدان بعض العلاقات الاجتماعية وانخفاض فرص الزواج. وبالنسبة لكلفة العمل، كانت مظاهرها خسارة العمل والخوف من فقدان فرصة العمل، وعدم وجود ثقة لدى المرضى النفسيين في القدرة على العمل، وتأثر عملهم الحالي. بالنسبة للكلفة المالية، لم توجد كلفة مالية مباشرة مرتبطة بالخدمة في المؤسسات الحكومية، لكنها كانت مرتبطة نتيجة للعلاج في الجهات الخاصة أو نتيجة للحالة المرضية. توصيات الدراسة: أوصت هذه الدراسة بضرورة إجراء المزيد من الدراسات والأبحاث حول موضوع الكلف الاجتماعية، على أن تأخذ الدراسات المستقبلية في الاعتبار استخدام منهجيات متنوعة، مع التركيز على كلفة الوصم الاجتماعي وكلفة العمل، وتحليل ارتباطها بعدة متغيرات أخرى في مجتمع الإمارات، مما سيسهم بتطوير سياسات الصحة النفسية وفقاً للأولويات وللمصلحة الفضلى للمرضى النفسيين. هذه نسخة من بعض المراجع، ونشكركم على حسن الاستماع. سننتقل الآن للمتحدث الرابع والأخير، الدكتور كريم عبد العزيز. تخرج الدكتور كريم عبد العزيز من كلية الطب من جامعة عين شمس في عام 2000، وهو حاصل على درجة الماجستير في الطب النفسي والعصبي في عام 2004، وحاصل على درجة الدكتوراه في الطب النفسي في عام 2010. انتقل إلى المملكة المتحدة في 2006 للحصول على درجات تخصصية، فحصل على البورد العربي في عام 2008. عمل الدكتور كريم في العديد من الوظائف في المملكة المتحدة، والتي تتعلق بالطب النفس عصبي كأخصائي ومستشار. منذ عام 2014 يعمل الدكتور كريم في جامعة الإمارات العربية المتحدة في مدينة العين، ولديه أكثر من 35 أوراق عمل علمية منشورة، كما شارك في أكثر من 23 مؤتمراً.
Welcome everyone. I'm going to present to you a topic on the neuropsychiatry of traumatic brain injury as part of the Abu Dhabi Mental Health Conference, December 2021. My name is Karim Abdelaziz. I'm an associate professor of psychiatry at the UAEU. No conflicts of interest to disclose. There are some learning objectives, TBI in terms of epidemiology, global burden, types and causes, mechanisms of pathology, TBI severity, and the neuropsychiatric sequelae and their management, whether cognitive, emotional, behavioral, or psychiatric. We'll start off by defining what traumatic brain injury is. So this is an alteration in brain function or alteration involving any evidence of brain pathology caused by an external force. And it's this external force that differentiates traumatic brain from other causes of acquired brain injury, like degenerative conditions, infective conditions, vascular conditions. And I'll come back to this idea of external force later on. It's manifest by either a change in conscious level, alteration of mental state, memory loss, or neurological deficits. Its incidence is about 2 per 1,000 people every year, so it's quite low incidence, with majority of cases being classed as mild. So 80% of cases are classed as mild, and this is what we call the post-concussion syndrome. So this is where there's a cluster of physical, mood, and cognitive symptoms that may last for weeks, months, or even years after the TBI. Early on, there tend to be more of the physical and cognitive symptoms in mild TBI. Later on, several weeks later, the emotional symptoms tend to predominate more than physical and cognitive symptoms. The symptoms tend to be self-limited, and permanent damage tends to be uncommon. In terms of prevalence, it's high prevalence, so 12%, and that's usually because a brain injury is usually for life. Males outnumber females by 2 to 1, 4 to 1 when it comes to mortality. Peak age of incidence is in young adulthood, so late teens, early 20s, and it's the leading cause of death under the age of 45, with a mortality rate of 25 per 100,000. The risk of TBI increases lower in the socioeconomic ladder, with alcohol being cases. Globally, about 10 million people are hospitalized or die every year. 57 million people worldwide have been hospitalized with one or more TBIs. In terms of the leading causes globally, it's motor vehicle accidents. The leading military cause is blast injuries. Similarly, in the Middle East, the leading cause is motor vehicle accidents, followed by military causes. The majority of those involved, 85%, are males. And it's not when you consider what driving in the Middle East is like. In terms of cost, there's a direct cost in terms of medical expenditure of $60 billion a year. And when you take indirect costs as well, in terms of loss quality of life costs, it goes up to $200 billion. I'm going to go back to this idea of the external force, which we said in the definition. So these include a number of types. So there's what we call the biomechanical forces. So this is the head striking or being struck by an object. Rapid acceleration or deceleration of the brain, such as a moving object. Penetration by a foreign object or a blast-related force. And this gives rise to two types of head injuries, what we call the open head injury, where the skull and the dura are perforated and where there's damage to the brain tissue, including necrosis. The object that passes through the brain. There's also what we call the closed injury, where the skull and the dura are intact. So the open injury tends to be more due to the blast injury and the penetrating injury, and the closed injury tends to be more from the biomechanical injury or the acceleration, deceleration. Biomechanical injuries involve, like we said, striking or being struck by a force. So imagine a person walking into a glass window. The site of the impact is what we call the coup injury. And there's the opposite side is what we call contra coup injury. In terms of acceleration, deceleration, normally we have the brain floating inside the skull with the CSF. A sudden deceleration, so if a car suddenly stops because of the momentum, the front of the brain impacts on the skull, or if the car suddenly accelerates, for example, the back of the brain impacts on the skull. And what happens is that the soft tissue impacts on the skull, producing two things, white matter injury and gray matter injury. So the white matter injury produces something called diffuse axonal injury because of stretching and tearing of the axons, what we call a shearing effect. And the gray matter injury results from bruises and contusions due to injuries of blood vessels. And these are the two main injuries involved. However, some TBIs involve white matter injury without gray matter injury. So with no involvement of blood vessels, CTs and MRIs are actually quite poor at picking up white matter injuries. So they may appear normal brain imaging. Secondary effects from the injury include cerebral edema, increased intercranial pressure, and cerebral ischemia and herniation. The major sites of vulnerability include the orbital surface of the frontal lobe and the tips on the side of the temporal lobe. There are a number of ways to measure TBI severity. So that includes the level of consciousness, the duration of loss of consciousness, and the duration of what we call post-traumatic amnesia. So level of consciousness is measured using the blood coma scale, which gives a score out of 15. It's actually a poor predictor of outcome in TBI. Duration of loss of consciousness. So this is a good predictor of severity with moderate and severe TBI. It's a poor predictor of outcome in mild TBI. The best measure that we have is the duration of the post-traumatic amnesia. So PTA is defined the onset of the injury and the return of continuous day-to-day memories. And we have tools that can measure that, called the GOAT, or the Galveston Orientation Amnesia Test. This is the best measure that we have, even for mild TBI. And so the GOAT involves asking a series of questions, and it's given a score out of 100. And if you score 76 or above, then you're normal, borderline between 66 and 75, impaired less than 66. If PTA is less than 1 week, then good outcome is predicted, and if it's more than a month, significant disability is predicted. And like we said, it's the best predictor of long-term neuropsychiatric outcome. So this is just a summary of how we class mild, moderate, severe, and very severe according to the 3 methods that we just mentioned. So in terms of the neuropsychiatric sequelae, about 5 million people, or 2% of the US population, live with disabilities resulting from TBI, and it's the neuropsychiatric sequelae that outstrips the physical complications as the major cause of disability. So these include 4 domains. So the first is the cognitive domain, so the short-term and long-term. So short-term, we've already talked about the loss of consciousness and the PTA. Most of these deficits resolve within a few months in the majority of patients. Long-term cognitive impairments affects about 2/3 of patients with moderate to severe TBI. A quarter of them will not return to work. An outcome is influenced by the duration of loss of consciousness, the type of pathology, and the person's morbid characteristics. The highest rates of recovery are in the first year post-TBI. After that, recovery tends to plateau, but improvements can be seen for up to 5 years post-TBI. The main cognitive domains affected are memory, processing speed, and executive functioning. And there are a number of neuropsychological tests can be used to assess that. There are different approaches, one being cognitive rehabilitation therapy, which aims at either restoring cognitive functions that have been affected or teaching compensatory skills for what has been lost. And there's something called goal management training that can be used. There are no FDA-approved medications, so any prescribing is off license. The best evidence we have for executive dysfunction is for dopamine agonists like amantadine or bromocriptine. Memory deficits respond well to cholinesterase inhibitors, and processing speed deficits respond well to stimulant medications like methylphenidate. Emotional deficits, again, can be seen early on as part of the post-traumatic delirium or post-traumatic amnesia. Longer term, these encompass 3 domains or 3 disorders or deficits: pathological laughter and crying, affective lability, and irritability. So pathological laughter and crying is characterized by intense, uncontrollable episodes of laughter and or crying that is incongruent and out of proportion to the situation, sometimes known as pseudovulvar affect or emotional incontinence. It affects up to 5 to 10% of patients in early TBI, who's recently very well acted out in a film called The Joker, which won an Oscar, and it's very well demonstrated. These medications, these disorders respond well to serotonergic and noradrenergic medications. SSRIs can be considered the first line. Affective lability is similar to pathological laughter and crying, but the outbursts of emotion or expression are congruent to the situation but are exaggerated and very intense. This can occur in up to half of TBI patients early on and close to 2/3 of late TBI, and they follow the same principles of management as pathological laughter and crying. Irritability involves transient outbursts of anger that are unpredictable, triggered by trivial stimuli and out of character to the person's premorbid characteristics, sometimes also known as intermittent explosive disorder, episodic dyscontrol. It can affect up to 1/3 of patients with TBI. The caregivers describe it as walking on eggshells, and it's ego dystonic in that patients later express remorse for their outbursts. Anger management and counseling are considered first line, so no treatment. Pharmacologic agents used, again, limited in the evidence base, but mood stabilizers have been used. Behavioral deficits involve disinhibition, aggression, and apathy. Disinhibition involves socially inappropriate, non-aggressive verbal, physical, or sexual acts that are out of social and cultural norms associated with impulsivity. It has to do with frontal lobe damage. It can affect up to a third of patients in moderate and severe TBI and are associated with poor long-term outcomes. Treatments involve behavioral interventions, so behavioral management, social skills training. Pharmacological evidence base is poor, but borrowed from other disorders like dementia, so things like SSRIs and anticonvulsants can be used. Aggression involves outbursts of physical violence that may be preceded by irritability, and can affect up to 80% of patients early in TBI, and up to half of patients in late TBI. It has an association with antisocial personality, certain characteristics, so it's reactive, non-planned, non-goal, not non-purposeful, so it doesn't serve any long-term goals. Explosive, it's intermittent, and ego-dystonic in that patients express remorse later on. Behavioral management is useful, and beta blockers are the only evidence-based pharmacological interventions. Apathy, on the other hand, is a general reduction in goal-directed behavior, cognition, and emotion, characterized by lack of initiative, increased interest and planning, emotional indifference and flat affect. And it ranges from 20 to 72%, with an overlap with symptoms of depression, but there are validated scales that can be used. So no RCTs for treatment of apathy, no evidence for behavioral interventions, small-scale studies involving dopamine agonists or stimulants. And finally, the psychiatric disorder. So the most common psychiatric disorder is depression. Affects up to 3/4 of patients. It can be diagnosed using the standard criteria. Depression is associated with the premorbid variables such as the genetic vulnerability in the psychiatric history, the type, extent, and location of the injury, and the degree of recovery and social support. Psychotherapy is a good option, such as CBT. SSRIs are first-line treatment with tricyclics, second-line treatment in ECT-resistant cases. Mania is rare, only up to 10%. Similar symptoms to non-TBI mania, with an overlap with symptoms of irritability, pathological laughing, and impulsive behavior. Limited evidence for the treatment. Valproate and quetiapine are the recommended first-line treatments, with other mood stabilizers being cautioned because of the risk of exacerbating impairments. Psychosis is rare but severe, again up to 10% of patients, with a mean latency from onset to injury to onset of about 5 years. It can take the form of delusional disorders such as Capgras or ubiquitous paramnesia, or schizophrenia-like psychosis involving delusions and hallucinations. Treatment, again, poor evidence base. Olanzapine is considered a reasonable first-line choice. And finally, anxiety disorders are quite high, so second highest after depression, so about 70% of patients with GAD and PTSD being the commonest disorders. Again, limited evidence base for pharmacology, but SSRIs supported by case reports. Benzos and antipsychotics are recommended to be avoided, with CBT always a good option. These are some of the references. And thank you very much.
نشكر البروفيسور طالب حنان والبروفيسور بعافية خالد والدكتور كريم عبد العزيز على مشاركتهم المثرية في هذا المساء، ونشكر جميع الحضور والمشاركين عبر مختلف القنوات، وعمتم مساء بكل خير.